Can I have your attention?
অটোমেটিক কানেক্টেড হয়েছে আপনি মনে আগে ক্লিক করে না কোনটা দেখি আগে ওয়াইফাইটা বোঝা যাবে
Good morning to everyone.
এটা তো হোটেলের তাই Good morning.
Okay, thank you everyone for coming. We are now starting.
Sorry.
And I hope that everyone has been prepared after a long flight. And maybe before we start, I would just like to make some housekeeping. And okay, one, the restroom is outside. It's just about 3 meters from here on your right. So if anyone needs okay, so regarding the presentations, for most of the presentations, I would like to with the time we have, because we know that time is always not enough, and we always like to discuss more. So, and with the chairperson who will try to allow the presenters depending on how much time is left, starting from 5 minutes downwards. So please, to gather all the questions that we have, because maybe during the discussion we might be able to answer all the questions. So we created a slide with the QR codes that you see on the table. So you can scan the QR code and send your questions to it. So and those questions, once that we did not answer during the discussion, so we will share it with the presenters and we will answer it and share it to everyone. So and about launch, so we are having launch at the 18th floor. So so and maybe before launch, so we are going to distribute the coupons that we supposed to be used for launch and we'll share it with everyone. So and on the tables, each of the tables we at least leave 1 or 2 spaces. So those spaces are not empty. So because after the lunch break, we are going to be joined by the civil society because they have a CSO meeting in another hall. So, and they will join us after lunch. So, and the space that we leave empty, so they are going to sit there. So, and the last thing is that, so I with the KNCV Vietnam team and the WHO Vietnam team will be the ones supporting you throughout. So if you have any questions or you need any support, you can approach us. So we are sitting there at table number 16 for any support. Okay, so, and that's all for the announcement. So and now we are going to start and I'm going to maybe call all the speakers who is going to share their welcome remark with us to come here on top. So starting with Agnes Gebhardt from KNCB Tuberculosis Foundation. Then Dr. Dinh Van from Vietnam NTP. Smalka from Unit 8. And Grania from the Global Fund. We'd like to have you on board here. And Dr. Angela from the WHO country representative. Thank you. Yeah, so and another thing maybe just to talk about it, so about the speakers. So with the interest of time, we are not going to go through all the biographies. So that's why we have a copy of the biographies in the folders in front of you. So, and please, you can always see it about the presenters and the speakers. Okay, so I will now like to call Agnes for the opening remarks. So Agnes is the technical director of KNCV Tuberculosis Foundation. Thank you very much, Agnes.
Thank you, Mansa. Good morning, esteemed colleagues. Director of the National TB Program of Vietnam, Dr. Dinh Van Loan. WHO representative of Vietnam, Dr. Angela. WHO colleagues from Geneva, regional and country offices, colleagues from Unit 8, from the Global Fund, NTB managers, laboratory directors, and distinguished guests, dedicated partners. We already here, we are with a mixed group of people. And it is my utmost honor and privilege to welcome you all to this important joint SEAR WPR regional workshop to plan the accelerated implementation of the new WHO-TB policies here in Hanoi, Vietnam. As we gather here today, we are united by our common goal to end TB. And we recognize the invaluable contributions each of you have been making towards ending TB. This week's workshop not only presents an opportunity to share knowledge and experiences, but also to foster collaboration and innovation in our collective fight against TB. Together, we face challenges that demand resilience, experience, and unwavering commitment. Efforts to end TB have been hampered by multiple uncertainties over recent times. Whilst recovering from the impact of the COVID-19 pandemic, we are now hit by natural disasters like the earthquake in Myanmar, which I would really like to think of the people who are suffering there. But also, on top of that, we are hit by man-made disasters and reductions of fundings that threaten to undo progress made over recent years. However, this should not stop us from being innovative and smart in finding ways to keep the effort to end TB on track. And I would like to take this opportunity to thank Unit 8 for their vision, stimulating innovative ideas to be brought to scale, and for their funding support to this meeting, as well as the WHO and Global Fund. Let this workshop serve as a platform for meaningful exchange of knowledge and experience, discussion of innovative ideas leading to actionable solutions. Together we can strengthen our strategies, amplify our impact, and move closer to the eradication of TB in our communities. So I look forward to an inspiring and fruitful discussion. And let's continue to work hand in hand to achieve a world free of TB. Together we can end TB. Thank you.
Yeah, thank you, Agnes. And so I may need to introduce myself first. And I'm Kyung Oh, from WHO Regional Office for the Western Pacific. Now I'm co-chairing this first session with Mansa. So I'd like to introduce the next speaker for the welcoming remarks, and then Dr. Angela Park, WHO representative for Vietnam. Yeah, please.
Thank you very much, and good morning, everybody. Let me begin by acknowledging, first of all, Dr. Dinh Van Loan, Director of the National Lung Hospital here in Hanoi and Chairman of the National TB Program for Vietnam. Colleagues from TB programs, national TB programs across Southeast Asia and the Western Pacific, partners, in particular donors, community-based organizations, researchers, WHO colleagues joining us from Manila, Delhi, and Geneva, and everybody else, colleagues and friends. So thank you again to the Vietnam National TB Program for hosting this important workshop. And on behalf of the World Health Organization and in particular the WHO Vietnam team, it's really my pleasure to be able to welcome you to the meeting today and to welcome you to Hanoi this week. As you all know, recently we marked World TB Day with the theme, as we've heard, Yes, we can end TB. But obviously, this is a very challenging and urgent and important, but very challenging task. Every year around the world, around 10 million people get sick from TB, and around 1.5 million people die, making it still the world's most deadly infectious disease. Global efforts, however, to combat TB in the last 2.5 decades since the year 2000 have estimated, we believe, around 79 million lives. But as we have also heard, major cuts to global health funding are sadly now threatening to reverse some of these gains, putting millions of people at risk, but at the same time making meetings like this one all the more important. Since we are meeting in Vietnam, I wanted to take a moment to say a few words about the Vietnam context and perspective, since it is the backdrop for your meeting this week. So like other countries, Vietnam faces a range of challenges. Limited resources, as is the case in all lower middle income countries, a high burden of TB, and much of that caseload in hard to reach populations. But in the face of these challenges, Vietnam's TB elimination program has had very strong commitment from the highest levels of the government, backed up with very strong and committed grassroots action from around the country, supported by hundreds, thousands of dedicated, hardworking healthcare workers. So as a result, in 2024, last year, Vietnam reported the highest number of TB cases ever, more than 113,000 notifications. Now, outside of this room, that does not sound like good news, but to this audience, you all know that the more notifications, the more people are being supported to get onto treatment. And of course, again, as you all know much better than I do, we will only end TB if we find every single person with the disease with an active infection and get them onto treatment. So this is a very great milestone for Vietnam, and my congratulations to Dr. Lung and all of your colleagues, especially the hardworking healthcare workers around the country working day in, day out to get people tested and get them onto treatment for achieving this very important milestone. So now back to the topic of this meeting. Over the next few days, you will all hear more about WHO's new TB management policies, which, when implemented in countries like Vietnam, will lead to better diagnosis, shorter treatment duration, better quality of life for patients, as well as significant cost savings, we believe, to the health system, all of which are necessary if we are going to achieve that big goal of ending TB. We will also have opportunities, or you will have opportunities, to share successes and challenges from different countries and learn from each other. And all of this will help to achieve, or is a step towards, a contribution towards achieving our collective aim through those 3 targets for 2027 that were set at the 2023 UN high-level meeting on TB in New York just a couple of years ago. So those targets are, firstly, making sure that everyone who is suspected of having TB receives a rapid diagnostic test. As of 2023, the rate was around 48%, so we basically need to double that. Second, we need to ensure, of course, that at least 90% of people with TB receive treatment. In 2023, the rate was 75%. And finally, thirdly, we need 90% of people in high-risk populations to be covered by preventative treatment. In 2023, among one of those high-risk groups, household contacts, just 21% of people were being treated. 21% of household contacts of people with TB were being treated. So again, very significant room to improve, which all of the tools that you will learn about and guidelines that you will learn about this week will help make progress towards. So let me just say again, we're very happy and proud to be supporting this meeting here in Vietnam this week. And I want to end just by saying that at a time where it does feel like global health is under threat, the importance of all of our work is under threat, it's worth taking a moment to reflect on the importance of meetings like this one, bringing together experts, partners, practitioners, all of you who work in national TB programs, together to discuss the important, painstaking work of applying global norms and standards to the very real contexts that you all work in. And it's this important work, painstaking, difficult, patient work that will help eventually to end TB. So I really want to thank you all for being here. On behalf of the WHO Vietnam team, I wish you an excellent workshop. And thanks again for having me here this morning. Singaman.
Yeah, thank you very much, Dr. Angela. So I would like to call the next speaker, Dr. Dinh Hinh Van Luyện from the NTP of Vietnam. Dr. Dinh.
Kính thưa bà Angela Pratt, trưởng đại diện của Tổ chức Y tế Thế giới tại Việt Nam. Kính thưa các quý vị, các diễn giả, các đồng nghiệp, bạn bè và tất cả các bạn.
Dear Angela Pratt, representative for WHO Vietnam Country Office, dear distinguished guests, speakers, colleagues, friends, and all of you.
Thay mặt Bộ Y tế, chương trình chống lao quốc gia Việt Nam, tôi xin gửi lời chào nồng nhiệt đến tất cả các quý vị khách quý, diễn giả, chuyên gia, đồng nghiệp và bạn bè từ 14 quốc gia tham dự hội thảo về bệnh lao liên khu vực tại Hà Nội, Việt Nam từ ngày mùng 1 tháng 4 đến từ mùng 1 đến mùng 4 tháng 4 năm 2025.
On behalf of the Minister of Health Vietnam and the National TB Program, I'm pleased to extend my warm welcome to all the distinguished guests, speakers, experts, colleagues, and friends from 14 countries to the bi-regional TB meeting in Hanoi, Vietnam from the 1st and the 5th of the 4th of April 2025.
Chúng tôi chân thành cảm ơn Tổ chức Y tế Thế giới đã chọn Việt Nam làm nước chủ nhà cho sự kiện quan trọng này và xin cảm ơn KNCV, United và Quỹ Toàn cầu đã hỗ trợ tài trợ chính cho cái sự kiện ngày hôm nay.
We are deeply grateful to WHO for choosing Vietnam as a host for this significant event. And we also thank KNCV, United, and Global Fund for their financial support.
Bên cạnh việc hỗ trợ các quốc gia cập nhật, triển khai các chính sách hướng dẫn mới của Tổ chức Y tế Thế giới, hội thảo này còn là cơ hội tuyệt vời để chương trình chống lao các nước từ hai khu vực cùng với các đối tác và chuyên gia gặp gỡ, chia sẻ thông tin, kinh nghiệm, triển khai tốt nhất và những bài học quý giá cho công tác kiểm soát bệnh lao trong tương lai.
Besides supporting countries in adapting the new WHO policy guidelines to their context, this workshop provides an excellent opportunity for NTB programs from the both regions, along with the partners and experts to meet, to share information, experience, best practice, and valuable lessons learned to enhance TB control effort in the future.
Okay. Kính thưa các quý vị đồng nghiệp, với dân số hơn 100 triệu người, Việt Nam có dân số đứng thứ 15 trên toàn cầu vào năm 2025 và là một trong 30 quốc gia có gánh nặng bệnh lao cao nhất thế giới. WHO ước tính vào năm 2023 thì Việt Nam có một tỷ lệ mắc lao là 182.000 trên 100.000 dân. và có 11.000 ca tử vong. Chính phủ Việt Nam đã khởi động kế hoạch chiến lược quốc gia vào năm 2014 nhằm giảm tỷ lệ mắc lao xuống dưới 20 ca trên 100.000 dân vào năm 2030 và một môi trường Việt Nam không có bệnh lao trong tương lai.
Dear colleagues, with a population of over 100 millions, Vietnam ranks 15th globally in 2025 and is one of the 30 countries with the highest TB burden in the world. WHO estimated that in 2023, Vietnam had a TB incident rate of 182 and 11,000 deaths. The Vietnamese government launched the National Strategic Plan in 2014, aiming to reduce TB incident to below 20 per 100,000 population by 2030 and create a TB-free environment.
Năm 2024, Việt Nam đã đạt được những cột mốc quan trọng trong phòng chống lao và kiểm soát bệnh lao, bao gồm số lượng báo cáo ca bệnh lao phát hiện cao nhất từ trước đến nay và duy trì tỷ lệ điều trị thành công cao. Chính phủ Việt Nam đã cam kết chính trị mạnh mẽ cho công tác phòng chống lao thông qua công điện số 25 của Thủ tướng Chính phủ, một công điện rất mạnh mẽ đã chỉ đạo để cho toàn hệ thống mạng lưới y tế Việt Nam, toàn hệ thống chính trị và vào cuộc để giúp cho kiểm soát lao. Và thứ hai nữa là Việt Nam đã vừa củng cố lại toàn diện kiện toàn Ủy ban Quốc gia phòng chống lao chấm dứt bệnh lao mà đồng chí chủ tịch ủy ban này là Phó Thủ tướng Chính phủ.
In 2024, Vietnam achieved significant milestone in TB prevention and control, including the highest number of TB notification and remaining the TB program. Also, Vietnam is consolidated the National TB Commission, chaired by the Vice Prime Ministers, and also to Prime Minister also issue the directive 25, number 25. It's one is a very important legal policy document to guide all the TB program to strengthen the TB network to control the TB in Vietnam.
Tuy nhiên, để đạt được các mục tiêu của kế hoạch chiến lược quốc gia, đặc biệt là thách thức do tác động đáng kể của đại dịch COVID-19 và tình hình bất ổn trên toàn cầu hiện nay, Việt Nam đã xác định các nhiệm vụ chính trong năm 2025 và những năm tiếp theo là gồm có 4 có 4 cái mục tiêu như thế này ạ. Thứ nhất là phải đảm bảo nguồn tài chính trong nước đầy đủ, bền vững và cả chính phủ cũng như trong khu vực tư nhân. Nguồn tài chính này sẽ đảm bảo các cái hoạt động phòng chống lao được duy trì liên tục, cho phép các nỗ lực phòng ngừa và điều trị bệnh lao được tiếp tục.
First, it is essential to secure the sustainable domestic funding from the both government and private sectors. This financial support will ensure that TB activities are continuously funded, enabling ongoing effort to prevent and treat the disease.
Vâng, thứ hai là việc huy động nhiều ngành và các tổ chức dựa vào cộng đồng là rất quan trọng để tăng cường phát hiện ca bệnh chủ động. Cách tiếp cận này đảm bảo rằng mọi người có triệu chứng của bệnh lao đều được tiếp cận, chẩn đoán và điều trị.
Secondly, involving multiple sectors and community-based organization, CBOs, is crucial for enhancing active case finding. This approach ensures that all individuals with TB symptoms have access to diagnosis and treatment.
Thứ ba, đây là điểm rất quan trọng mà năm nay là toàn bộ triển khai của chương trình chống lao quốc gia sẽ triển khai theo cái tinh thần như thế này. Đấy là tích hợp các cái dịch vụ khám chữa bệnh lao với các chương trình y tế khác bằng cách củng cố mạng lưới y tế chăm sóc cơ sở. Đó là kiểm soát lao gắn với các cơ sở khám chữa bệnh, gắn với toàn bộ kiểm soát kiểm tra sức khỏe định kỳ, gắn với toàn bộ hệ thống kiểm soát chủ động, chăm sóc kiểm soát các cái bệnh của tuyến cơ sở, mà gắn với hồ sơ điện tử, kiểm soát hồ sơ điện tử. Như Việt Nam thì hiện tại Việt Nam là đã kiểm soát được 20 triệu hồ sơ bệnh án điện tử và phấn đấu sẽ đạt đến 50-60 triệu hồ sơ bệnh án điện tử. Và trong hồ sơ bệnh án điện tử đấy thì ta sẽ làm kiểm soát lao ở chính những bệnh nhân như vậy. Đây là cái nội dung rất quan trọng mà chương trình chống lao quốc gia Việt Nam năm nay sẽ triển khai với sự can thiệp cam kết rất mạnh mẽ của hệ thống chính trị.
The third one is the most important. For these years, the government of Vietnam have to try, and TB program try to integrate the TB service with all the healthcare services and all other public health programs by in reinforcing the primary healthcare system and create a more comprehensive and efficient approach to the healthcare deliveries. This year also Vietnam is launching the electric health records for all the Vietnam citizens. So far, the Vietnam already achieved 20 million electric health records for the citizens, and also want to increase to double of that in a couple of years, including the TB program in this electric health records.
Và tôi nhấn mạnh lại cái nội dung thứ ba này rất quan trọng và chúng tôi năm nay sẽ triển khai đúng như cái tinh thần của cái nội dung thứ ba này. Nhấn mạnh.
I re-emphasize that is activity is one of the most hours important for this year.
Okay. Thứ tư là cuối cùng thì tăng cường hợp tác quốc tế là rất quan trọng để cung cấp các cái dịch vụ chăm sóc chất lượng và các can thiệp hiệu quả. Việc nhanh chóng triển khai các chính sách, hướng dẫn, phác đồ, công nghệ và đổi mới của Tổ chức Y tế Thế giới sẽ giúp giữ cho các cái dịch vụ khám chữa bệnh lao luôn cập nhật và hiệu quả.
Finally, strengthening the international cooperation is vital for providing quality care and effective intervention, swiftly implementing new WHO policies, guidelines, regimens, technologies, and innovation will keep TB service up to date and effective.
Ok. Với sự hỗ trợ kỹ thuật, tài chính từ Tổ chức Thế giới, KNCB, Quỹ toàn cầu và các đối tác khác trong những năm qua thì đã đóng vai trò quan trọng trong việc kiểm soát bệnh lao ở Việt Nam và các quốc gia khác. Chúng tôi biết ơn sự hỗ trợ không ngừng của các bạn và mong muốn sự tiếp tục hợp tác trong tương lai.
With the technical and financial support from WHO, KNCB, Global Fund, and other partners over the past years have been very important in combating TB in Vietnam and other countries. We are grateful for their continuing support and look forward to continue collaboration with you in the future.
Cuối cùng thì tôi hy vọng tất cả các bạn có mặt có một thời gian tuyệt vời tại hội thảo đầy ý nghĩa này và tận hưởng cái việc khám phá Hà Nội, thủ đô xinh đẹp của chúng tôi trong những ngày tới. Xin cảm ơn. Thank you.
Finally, I hope you all have a wonderful time and an insightful meeting and enjoy exploring Hanoi, our beautiful capital, in coming days. Thank you.
Thank you.
Thank you, Dr. Dean. And then, so I'd like to introduce the next speaker, Smilika de Lucini from Unity.
Thank you so much, and good morning, everyone. First and foremost, really very special thank you to the Ministry of Health of Vietnam and the National TB Program. I think it's very special actually to be here, knowing how much Vietnam contributed evidence and knowledge base for WHO. recommendations across the board. And the point of this meeting has always been to speak about the new recommendations, and it's interesting also to acknowledge as well the Vietnam contribution to that process, and so thank you for that. It is actually very special to be here for another reason. When we thought about this meeting some months ago and we started planning it, it was really focused about that kind of, in a good way, perfect storm of recommendations and normative guidance that was coming out from all the directions of TB response, starting from prevention to screening, diagnosis, and treatment. And we are really at that kind of cusp of resolving some of the key issues that we've been having in the TB response since decades. On the other hand, since January, we are facing another, maybe not as big, but definitely very disruptive perfect storm of financing issues that completely, at least in our perspective of a donor of this meeting, changes how we would like to see the conversations going on over the next 4 days, especially knowing what privilege it is to sit in this room and have you all come and leave your very intense work and populations that you are serving nationally to actually speak to us. So as a partner in this journey of TB response, we would like to really shift the focus of more listening than speaking over the next 4 days, and being able to actually return to Geneva and inform some of the important investment and financing decisions that we will have to make over the next months. UNITAID, since 2 decades, has been at the forefront of the TB response. We always took challenges very straightforward and tried to resolve them with innovation. And we do remain convinced and committed that the innovation is what will get us through this perfect storm, especially when we speak about issues of financing that will have to be tackled differently than doing business as usual. We do know that quite a few innovations will help us think this through in a more cost-effective and cost-saving way. And those are kind of angles that we would like to position some of the conversations on new recommendations about. As I said, our commitment remains. We have several new investments in TB lined up that we will be announcing soon. We are still thinking about what is new in the pipeline, but really at this point and over the next 4 days, we would like to ask you to help us how to navigate this new situation and really give us the perspectives across 2 fronts. The first one is really around the country readiness and the country commitment across the board to TB. And these are the questions that are being asked at the level of where we sit, especially in the sense of the competing financing priorities when the budgets are actually reducing. So if you can help us really navigate on how to think about pacing ourselves to support this process, that would be really important. And the second one is really about country priorities. We are not the ones who should be setting it, and if that ever came across, I think it's something that we never intended to. So as we are talking about different issues over the next 4 days, it would be really good to get the input from you and the highlights on what those priorities should be and where we should put more focus, because we will not be able to address everything right at the same time. Thank you so much for taking time to come and for leaving very important tasks at home. It is a privilege to be here, and I'm looking forward to the interactions over the next 4 days. Thank you.
Thank you very much, Sunilka. So, and the next speaker is Granier from the Global Fund. So Granier is a senior TB advisor at the Global Fund.
Thank you very much and welcome everybody with all protocol observed. And I'd like to thank the organisers and the Vietnam NTP programme for the opportunity to address this important workshop on accelerating the implementation of WHO TB policies. And I'm very honoured to be joined in the room by representatives from 9 high-burden TB countries across Southeast Asia and the Western Pacific regions, as well as additional colleagues online, including our colleagues from Myanmar, whom I send our thoughts for the current situation, as well as being joined by our valued technical and funding partners in the room. The WHO policy updates on TB prevention, diagnosis, nutrition, and DER TB treatment help ensure that the latest science is translated to policy. And it is important that these right policies are in place in the national context in a timely fashion, but actually it is moving from policy to implementation of these policies that is where the most impact lies. And this requires updating the guidelines, training the healthcare workers, securing the resources to give access to quality care to all. TB programs in the room and in the region have demonstrated remarkable leadership in implementing some of these policies. And this workshop represents a great opportunity to learn from each other about how to scale up the latest rapid molecular diagnostics. As we've heard, currently our global coverage is only at 48%, but there are good examples in this room of how countries have tried to increase that, and how to implement the shorter regimens for drug-resistant TB, childhood TB, and TB preventative therapy. This brings cost savings for the programs, cost savings for commodities, but most importantly, makes the treatment journey for people with TB shorter with the same outcomes, if not improved outcomes. The Global Fund remains committed to supporting your TB programs through flexible country-led financing. In our latest allocations cycle, we have prioritized the latest WHO guidance and how to support countries to accelerate the adoption of these guidance through the use of our Global Fund program essentials. And we continue to work closely with national programs, with civil society organizations in countries, and our valued partners like WHO, UNITAID, Stop TB Partnership, Gates Foundation, and others here in the room to ensure that we provide complementary support to your programs to ensure that you can implement the latest guidance. So this workshop represents a unique opportunity to learn from others in the region and share your learnings on how to implement the current WHO guidance. But it also helps us prepare for future innovation. The final days focused on new diagnostic development is particularly exciting, as there is potential for more affordable, near point of care tests. But for these and any other new tools in the pipeline to achieve maximum impact, we need to ensure that the current guidelines, the latest guidelines, are in place. And these create pathways and approaches for ensuring future innovations in the pipeline are accelerated and scaled up. Your insight and knowledge of your diagnostic networks and the challenges you have will be crucial for determining how to integrate new tools, particularly new diagnostics, into existing systems. So we do look forward to hearing your thoughts and opinions on this on Friday. So in conclusion, I would reiterate my thanks to the Vietnam NTP program for all their support and leadership in bringing this meeting together today, along with the colleagues from KNCV, UNITAID, and the WHO regional offices for their help in bringing everyone in the room today. And I'm looking forward to the discussions this week as you all work together to strengthen the TB response in your national programs and across the region. Your leadership is essential for achieving both the ambitious UN HLM meeting commitments and ending TB by 2030. I'd like to thank you for your dedication to this work. Thank you.
Thank you, Grania. And so, yeah, thank to all speakers for welcoming remarks, and that you may get back to your seat. And then next one is the introduction of participants. So in the interest of time, so that I give you a 5 seconds per person, so that when you introduce yourself, just stand up like me, and then to show your face to everyone, and then say your name, affiliation, and country. And then also we'll take a round from table 1 in numerical number order, 2, 3, 4, 5, 6, and like this. And also within a table, just take a round. And then after that, pass to the microphone to the next table, and those take a round, and then likewise. So, okay, let's start from table 1. Yeah, please.
Good morning, everybody. I am Dr. Jahangir Kabir, working as a program manager in Bangladesh, National Tuberculosis Control Program. Thank you, everybody.
Good morning. I am Dr. Fateh Akram from Bangladesh, and I work as a superintendent of TB Control Institute and here for childbirth. Thank you.
Hi, good morning. I'm Snehashish Das. I'm now working as Senior Assistant Secretary under the Ministry of Health, Bangladesh. And here I'm participating as a lab person. Thank you.
Hi, good morning. My name is Melinda Sumarno. I'm Technical Advisor from Yayasan KNCV Indonesia. Thank you.
Hi, good morning. I'm John Sugiarto from Yayasan KNCV Indonesia. Thank you.
Good morning. My name is Dr. Galu from NTP Indonesia. Thank you.
Good morning. Sawadee krap. I'm Dr. Kraisorn Totapiang, NTP Thailand. Thank you.
Good morning, everyone. My name is Hương Đinh. I'm from Vietnam NTP.
Good morning, everyone. I'm Dr. Nguyễn Bình Hòa from Vietnam NTP.
Good morning, everybody. I'm Nguyễn Đình Tuấn from the NTP Vietnam.
Good morning, everybody. I'm Khun Kum Im from the NTP Cambodia.
Sabaydi. Good morning, everyone. I'm Suvimon Sipantong from NRLTP of NTP Laos.
Good morning. I'm Dr. Sakon from NTP Laos.
Good morning, everyone. I'm Naranotha. I'm a lab officer from NTP Cambodia. Nice to see you all.
Good morning. I'm Dr. Navin from Nepal. I'm a chief consultant at NTP.
Good morning, everybody. I'm Som Hun from local NGO from Cambodia. Thank you.
Good morning, everyone. I am Vân. I'm from Vietnam NTP.
Good morning, people. I'm Dung from NTP Vietnam. Nice to meet you.
Good morning, everyone. My name is from Vietnam NTP. Nice to meet you.
Good morning, everyone. My name is Thanh. I'm from Vietnam NTIL, Vietnam NTP.
Good morning. I'm Dr. Huyền from Vietnam NTP.
Good morning. I'm Dr. Sayakato from Research Institute of Tuberculosis, Japan Anti-Tuberculosis Association.
Good morning, everybody. My name is Dr. Hằng. I'm from Vietnam NTP.
Hello, good morning. My name is An Enes. I'm an independent consultant and I live here in Vietnam.
Good morning. My name is Zaza Muñez. I'm from the Stop TB Partnership Global Drug Facility.
Good morning, everyone. I'm Kavi Velen from the TB program at FIND based in Geneva.
Good morning, everyone. I'm Stikter from NTP Mongolia.
Good morning, everyone. I'm a Mongolian NTP manager. My name is Gan Dongseok.
Good morning, everyone. I'm Gordon Pukai, a pediatrician from Papua New Guinea and the focal person with the Child TB program with the Pediatric Society of Papua New Guinea as well as the PNG National TB program.
Good morning, everyone. I'm Jennifer Banamu, TB Reference Lab, Papua New Guinea.
Good morning, everyone. I'm Dr. Erin Indil. I'm the manager for National TB Program. Thank you.
Good morning. My name is Linh Nguyen from TB treatment team, Global TB Program, WHO in Geneva, Switzerland.
Good morning. My name is Puneet Dewan. I'm a program officer for TB with the Gates Foundation based in Seattle, US.
Good morning. I'm Anisa Gadrashenas. I'm here with Unitaid from Switzerland.
Hi, everyone. I'm Vindhya. I'm from Clinton Health Access Initiative, Vietnam.
Good morning, everyone. My name is Han Nguyen. I'm from France for International TB Relief, Vietnam.
Hi, my name is Tu Anh Nguyen, and I'm director of the University of Sydney Vietnam Institute. I'm from Vietnam.
Morning, everyone. My name is Arnab Pal. I'm with the TB program at CHAI.
Hi, I'm Claire Albert-Watkins with the Clinton Health Access Initiative Global Tuberculosis Team.
Good morning. I'm Cecily Miller from the Global TB Program at WHO Geneva.
Good morning, everybody. I'm Annabelle Badley, also from the Global Program of TB and Lung Health in Geneva, WHO.
Good morning. Vineet Bhatia, working as regional advisor for TB in the WHO Southeast Asia Regional Office.
Good morning, everyone. Patricia Hall-Edson with the diagnostics team at the Global Program for TB and Lung Disease in Geneva.
Hello, everyone. I'm Huyền. I'm a doctor of Vietnam National Pediatric Hospital. Thank you.
Good morning. My name is Ngọc. I come from Vietnam National Children's Hospital. Nice to meet you.
Good morning. Eden Mendoza-Heisey from TB Alliance.
Good morning. My name is Greg Fox. I'm representing the NHMRC Centre for Research Excellence in Tuberculosis at the University of Sydney in Australia.
Good morning. I'm Ian from the University of Sydney Vietnam Institute.
Hi, my name is Julia Tuttle from CHAI.
Xin chào, hello. I am Giang from the University of Sydney Vietnam Institute. Nice to meet you all. Thank you.
Good morning. I'm Phượng from Vietnam.
Good morning. I'm Dr. Thuy from PMDT Unit, Vietnam NTP. Thank you.
Hi, good morning. Mamel Calapio from the Philippines, independent consultant connected with KNCB and TB Alliance.
Good morning, everybody. My name is Hà. I come from Vietnam NTP. Please.
Good morning. I'm Dr. Hiền Mai from FHI 316 Vietnam.
Good morning, everyone. I'm Dr. Hà Nguyễn from FHI 316 in Vietnam.
Good morning. I'm Dr. Hương Nguyễn. I'm from FHI 316 in Vietnam. Thank you. Nice to meet you.
Good morning, everyone. I'm Lượng from FSI 360.
Good morning, everyone. My name is Tuấn Lưu. I'm from TB team from CHAI Vietnam.
Good morning. I'm Dang Ngo from Clinton Health Access Vietnam.
Hi, I'm Sharon Ann Lynch. I'm with the Diagnostics Equity Consortium and the O'Neill Institute at Georgetown University.
Hi everyone, I'm Rachel Byrne, the Diagnostic and Paediatric Lead for Start for All, a Unitaid funded project.
Hello everyone, I'm Melanie Kitongo from the Global Fund.
Yeah, good morning, everyone. I'm Hương Nguyễn from KNCV Vietnam.
Good morning, everyone. This is Quỳnh from KNCV Vietnam. So I think that's all of them, of us.
Okay, thank you all for introducing yourselves. And then, so I understand there are some online participants, and then how many? The online participants, can you introduce yourself?
Good morning. And Mumbai from India. I'm Dr. Nishan. I'm Joint Director with the India TB program and with Ministry of Health. I'm the focal person for the lab network in India. Thank you.
Good morning, everyone. I'm Dr. Hiếu from WHO Office, Vietnam. Nice to meet you all.
Any more online or offline participants?
Okay, my name is Mansa from KNCB Tuberculosis Foundation Global Office. Nice to meet you all. Okay, so then we're going to continue. So we have other people online, but it seems that they don't have access also to speak. So that's why, but we know that they are here with us. Yeah. Okay, we'll continue with the other activities. And this one is to talk about the objectives and structure of the workshop. So, and Agnes Hepart from KNCB Tuberculosis Foundation will take us through. Agnes.
So good morning again. We will do this quickly because I think you have all been able to read and to see what the aim and objectives of the workshop are and what the format of the workshop is. But just to summarize, that the aim, of course, is to facilitate a smooth transition to WHO's new policies at country level. And I think the earlier speakers have summarized quite nicely what this entails, so I will not repeat that. Then the objectives of the workshop, which we will be working on together, is first to strengthen technical expertise among country representatives and enhance understanding and application of the latest WHO guidelines and the operational handbooks on preventive treatment and screening, TB diagnosis, treatment of drug-resistant TB, and nutrition for people of all age groups. This we are not only doing here in this room, but we're also doing that in the room with civil society representatives who will join us in the afternoon. The next objective is to improve knowledge on advanced diagnostic approaches for TB screening and diagnosis. We want to discuss country experiences and implementation drivers and barriers regarding adoption of the latest WHO recommendations to share good practices and review to overcome constraints. And maybe most importantly, to plan the next steps you can take in your countries in optimizing the TB response and transition plans for uptake of the innovations. The last day, we will have a special day to understand the pipeline of non-sputum and or peripheral tests for the detection of TB, discuss their relevance and potential to address current challenges, and to review possible use cases and essential requirements for country adoption and implementation. And this last day of the workshop will be very important to inform next steps. Also for the funders on which direction to move. So broadly, the format of the workshop, there will be presentations presenting the latest guidelines. We're trying to keep that as short as possible in order to leave space and room for you to hear the country experiences and then discuss these country experiences, how you can make these useful in your own countries, or how you can scale up or introduce the recommendations from WHO. So I leave it at this, and I wish you a good workshop.
Yeah, thank you, Agnes. And the next presentation is a scene setting by unit 8, and will be presented by Anissa Kadshinas.
Good morning, everybody. My name is Anissa Gadroshenis, as I introduced earlier, and really welcome everyone to this important meeting, and recognize that many of you have traveled from different countries during Eid, and we really appreciate your presence here. And I echo thanks to our colleagues from Vietnam for hosting us. So I will quickly synthesize maybe some of the points that our colleagues have already referenced earlier, because I think that seeing it on a couple of images, I'm a visual learner. So here, perfect. So it was just 1 week ago that we were marking World TB Day. And the theme this year has been, yes, we can end TB. Really sort of looking for a renewed commitment to innovation and partnership, but also acknowledging the progress that countries have made. So while there are these concerns and the present challenges that have been raised by folks earlier, there's also a lot of progress to acknowledge from the work that NTPs, NRLs, and the partners in the room have been doing. So we recognize that, these challenges present new concerns that we need to work together to address, but recognizing the presence here, the renewed sort of call from the high-level TB meeting last year, our commitments on World TB Day, and a reminder of what the tools are, what the guidelines are that can get us to respond to the crisis is really encouraging. So we have hope, but also some concerns that sort of are hand in hand at this point. And we're excited to kind of have a few days together to explore that. At UNITAID, for those of you who are familiar with us, we have been working across TB for many years. And even at this juncture, we remain committed and undeterred, and recognize that the next few years are actually going to be quite pivotal in the response to TB. To date, we have invested over $250 million. Our projects are currently in 30 countries, and with 8 different consortium groups, many of which are in the room, and countries that are in the room. And I think when we look across the cascade of screening, prevention, testing, treatment, we see the need for a holistic response. And then that's how the guidelines are responding. And that's how we've framed our investments, to really look at gaps that are in the health system and identify innovative solutions, particularly where markets have failed, where there's a need to kind of bring in innovations that can accelerate access to affordable diagnostics or treatment tools, in particular for drug-resistant TB and TB prevention, but also for vulnerable populations in the cascade of care. So I think there's a strong parallel between the way countries have organized their programs, the way WHO is responding, and subsequently the way donors like Unitaid, but also Global Fund and Gates and others in the room are responding to this need. And so as we're convening at this very critical time, we were reflecting on some of the opportunities and framing that would make synthesis of the discussions to come this week. So we're seeing a lot of opportunity to think through some of the innovations. There are new opportunities in the innovation space, new tools, but also new approaches. Whether those are algorithms or interventions that can improve retention in care. And we think that that's a big opportunity, and we welcome your feedback on that piece of the response. Effective implementation is also a huge part of why we're here. We have a call from WHO to advance the guidelines, which we'll learn about this week. But this will sort of need comprehensive national strategies and policies to drive uptake and to show impact of these guidelines. But we know that country ownership is sort of the forefront of the response, along with our community leadership and powered by civil society. And we are thrilled that there's a parallel meeting taking place just upstairs. But it's countries that will be in the best position to shape and decide how both the innovations and the normative piece will make sense in the context and amongst other priorities. So we're thrilled to kind of have these discussions together, as well as with our partners. So thinking through coordinated action, a multi-sectoral response, as well as recognizing the comment from our colleague from Vietnam that we're going to also need strategic and sustained financial investments, and investments in resources to reach our targets and see better health outcomes. So this is really an opportunity for us to connect across country experiences, understand some of the operational realities, and look to sort of the normative guidance to see what's coming next. And so we appreciate your insights. I think my colleague earlier flagged that these are useful for our learnings with each other, but also for us as partners when we're refining our strategies, our investments, to make sure that they really support countries and maximize the impact from that perspective. And that's it. Thank you very much. And I wish you a very fruitful week. And thank you again to our colleagues at KNCV as well for their hard work in organizing this week. Thank you.
Yeah, thank you very much, Anise. So yeah, we'll go to the next presentation. So, and this will take us through to the WHO policy updates on prevention and screening. So, and Avinash, a medical officer from WHO Global Office, will take us through the presentation and give us updates on TPT guidelines and the operational handbook. So we have a pre-recorded presentation.
PowerPoint combination. The next is just a word about the United States. Electricity and can procure them for $50 per month. And because
trial from South Africa among children. The overall meta-analysis of the data from these two trials shows about 60% protective effect of levofloxacin compared to the placebo, and it is there's a likelihood of about 98% that levofloxacin can prevent TB among those exposed to MDR-TB. Although the recommendation on levofloxacin is recent, we noted in the last year's global data collection for the Global TB report that about 33 countries already had some experience of use of levofloxacin based on our previous recommendation. And in the Southeast Asia and Western Pacific region as well, we have some experience, and some of it will be presented in this session. So along with the second edition of the TPT guidelines I mentioned, we also published the second edition of the operational handbook, which provides complementary details that help countries to plan and implement TPT. And I'll mention a few things in subsequent slide, which would be relevant to scale up of DR-TPT. One of the updates that you will note in the operational handbook is the combined algorithm for screening and testing before TPT started. We have included the new tools that are now recommended for screening among all populations, the C-reactive proteins, chest X-ray, and the rapid diagnostics like GeneXpert. But also the role of testing for TB infection among adult contacts as well as other risk groups. So this is the second important update that I wanted to mention in the operational handbook. We have this drug dosing table now, which is updated, and the weight bands have been revised to align with the overall WHO weight banding for different programs. The recommended dosing is now available for 3 HP for all age groups now, down to 3 kg weight. And also the dispersible formulations of 100 milligrams isoniazid and 150 milligrams rifampicin are now available, and you can find the dosing in this table. The FDCs are also there, and they are recommended for older children and adults. For levofloxacin as well, we have recommended dosing for both the dispersible formulations as well as the solid formulations of 250 and 500 milligrams. The operational handbook also has a detailed section on the safety and management of adverse events in there. This slide is to show the evidence that was presented to the guideline development group on safety. You will note that the grade 3 or above adverse events or grade 3 or above serious adverse events, there is no real difference between the levofloxacin group and the placebo. However, grade 3 or above adverse events which were attributed to the study drug, we note a difference between the Wequin and TB champ. Wequin, remember, was among adults, and we see statistically significant difference in the serious adverse events in the levo group compared to the placebo in the Wequin trial, but not in the TB champ trial. Also, the data indicates that participants receiving levofloxacin are significantly more likely to discontinue TPT due to adverse events compared to those receiving placebo. In the Wequin trial in particular, the difference is statistically significant. In the TB champ trial, although more kids developed or stopped TPT due to adverse events, numerically the difference wasn't statistically significant. The range was wider. The data also indicates significantly increased risk of musculoskeletal adverse events among individuals receiving the levofloxacin compared to the placebo. It also is quite evident from this analysis of heterogeneity between the two trials that children tolerate levofloxacin far better and face fewer musculoskeletal events compared to the adults, which was the key population study in the Wequin trial. So let me summarize the adverse events due to levofloxacin that was seen in the Wequin and the TB champ trial. Overall, the good news is levofloxacin is very well tolerated by children. The second good news is although a large proportion of individuals develop some adverse events, most of the adverse events are not serious and they can be managed clinically. Adults face more musculoskeletal events. Again, these can be managed. The arthritis, arthralgia, tendinitis can be clinically managed often. The treatment discontinuation is overall uncommon, infrequent, and the usual reasons that people may stop the TPT could be symptoms like dizziness, headache, nausea, abdominal pain, which should be quickly noted and managed by the programs. Coming to the cost of the DRTPT regimens using the formulations that are on market and also available on the GDF catalogs. For an adult TPT course, using 500 milligrams levofloxacin would cost about $9. For children, it would be about $5 using these 250 milligram non-dispersible. A dispersible formulation is also available. However, it's quite costly right now. The TB-CHAMP trial, however, did a cost effectiveness study using this dispersible formulation, and what they concluded was in the long term, even if the regimen is expensive right now, it would be cost saving for the program. And as countries take up TPT and scale up, we hope that these costs of the dispersible formulations go down. So one important concern that we have heard from national programs is on high quinolone resistance, and this applies more to countries in Asia. In these situations, what we recommend is DRTPT should still be considered if the programs have capacity to undertake drug susceptibility testing for the source patient and get the quinolone resistance tested. That would be good. If the person is found to be resistant, alternative options like ethionamide and ethambutol, which have been tried in some studies, can be used based on the DST profile. However, these regimens, you would understand, are weaker compared to the levofloxacin regimen. We are hoping to have more options, and one of the trials that would soon conclude is the Phoenix trial, which is testing 26 weeks of delaminid compared to the isoniazid among the contacts of DRTB patients. We are hoping to have these results soon, and by the end of the year, as they become available, we are hoping to update our recommendations based on this study. The operational handbook also has a dedicated chapter on recording and reporting. We encourage countries to have a strong TPT program data elements integrated into the national HMIS, and at least the basic data elements across the cascade of TPT care should be captured, like how many people are evaluated, how many get started on TPT, and of them how many complete. And if we could capture reasons for not starting TPT or the different adverse events that individuals face, it would be very useful for the programmatic scale up.
To enable digitization of recording and reporting of the screening and TPT cascade, WHO developed this mobile application, the Prevent TB application, and we have been updating it since then. And we have piloted it in several countries, including some in these two regions. We have added new features to the platform. We have now modules to monitor adherence and also report adverse events. The platform itself is built upon the DHIS2 architecture, and it can be integrated within the broader DHIS2 deployment in the country, or if the country has another electronic system, it can still be integrated, and we can extend all the support that is required for this. Coming towards the end of my presentation, let me point you to the WHO TB knowledge sharing platform, which hosts all the latest guidelines and handbooks and also training content. It also comes on a mobile platform. Also, there are new features that are recently added. You can find a drug dose calculator, which can be very handy. And then we have very recently added this beta version of this AI-enabled search, and we would encourage you to explore this platform and feedback.
So this is my last slide, and I would just summarize what I've said in the presentation. And the first and most important point would be for the national program to develop the guidelines for use of levofloxacin for DRTPT if it's not yet done. Allocate resources for scaling it up. build capacity of the staff, including protocols for screening, the baseline assessment, management of the adverse events. The contact tracing, which we have been doing for drug-sensitive TB patients, needs to be also emphasized for the DR TB patients now, so we could offer TPT. Ruling out TB disease is a key requirement before TPT started, and we encourage countries to use the chest X-rays, C-reactive proteins, MWRD, as and where they are available. We also encourage testing for TB infection wherever feasible before TPT started. The DST for the source case would be important, particularly for the use of levofloxacin in high fluoroquinolone resistant setting. Baseline assessment needs to be done to check if there are contraindications for long-term levofloxacin use, like existing tendon disorders, CNS conditions, pregnancy, or known hypersensitivity. Regular clinical follow-up, so we pick the adverse events quickly and manage them clinically, so people don't stop TPT. We may also need to extend adherence support, some counseling, and monitoring and evaluation needs to be in place. So we are able to track the patient outcomes, adherence rates, and adverse events. So I will stop by acknowledging people affected by TB, the national TB and HIV programs, the guideline development groups, my WHO colleagues, and our donors. And I thank you, and I will be happy to take if there are questions.
Yeah, okay, thank you very much, Avinash. So we don't have Avinash here, and it's not online. So, but we have colleagues from WHO. So now the floor is open for question, any discussions that you have. So if there is any question that we cannot answer, we'll try to ask our WHO colleagues for any support, or if not, we can gather all the questions and send it to Avinash. So please, you can use the mics, or if you have any questions, or still you can send your questions also online. Any question, comment? WHO colleagues, do you want to comment on any of the informations that you hear today?
Does it work now? Actually, I think it would be very nice if people would come to the mic and post their questions. That is so much more personal than just typing it in your app, in your mobile phone. And I would have a question to some of the countries which I saw on the list of Avinash. That have already experience in the use of levofloxacin for contacts of people with drug-resistant TB. So if I saw well, I thought that Indonesia was already on the list of using it. Is there any experience you can share on that?
Thank you, Agnes. So the team from Indonesia, you want to share any?
Thank you. About the implementation of levofloxacin as TPT drugs for contact with drug TB resistant patient. We already implement in Indonesia, and it's very useful, and it works. But maybe something I would ask about skin tests. Yeah. Now in Indonesia, this year we have new policy about skin tests for TB infection. We already distribute circulate letter to subnational levels that we don't use a skin test for household contact because we assume that all household contact are eligible for TB. I don't see where is the urgency of skin test for household contact. I mean, is that just for proof that the household contact is already got infected or not? I think is not too important. I want to ask about your guys' opinion about that. Thank you.
Yeah, thank you very much. So WHO colleagues, so maybe your opinion about the skin tests for household contacts?
Yes, that's a very good question. And we will have a session on tests for TB infection this afternoon, so we can dive more into that. But just overall, we do really encourage the use of tests for TB infection if at all possible, even for contacts above the age of 5. Under 5, it's felt you can go ahead with preventive therapy. You don't need a test, but we do really encourage the use of tests for infection in the adults and adolescents over 5. We see from systematic reviews that the burden of infection is maybe around 50%. So you can really target the intervention to, the half of the contacts that are really much more likely to progress to have a risk to progress to infection. Having a positive test really improves the uptake for the TPT for the contacts and for the physicians to reinforce. So, and we'll learn more about the newer, better tests that we have now to try and help with implementing this.
Yeah, thank you, Cecily. So, and we'll have a presentation about that. So you can still gather more questions for her after the coffee break. Yeah.
I'm Dr. Mohd Jahangir Kobir. I'm from Bangladesh. I'd like to ask a question to Mr. Avinash. I think he has given an explanatory presentation to us, but I'd like to know from the Avinash whether India is developed a DRTB preventive treatment guidelines or any SOP in India. Is it still operating or not? And what is the exact coverage of the DRTB preventive therapy in India? I'd like to know from the Avinash. Thank you. Thank you for my side.
Okay, thank you very much. Repeat. Okay, thank you. Yeah, I think we have one question from there.
Thank you. Can you hear me? Yeah. Just wanted to reflect on the experience in Vietnam through the VQuin trial, and just to acknowledge the National TB Program's amazing contribution through that trial to the data that you've seen today. When people are tested using TST, it actually is very important because some of these drugs can cause low-grade side effects. And so if people don't think that they have any evidence of any problem, then they often don't take their treatment. And we found in VQuin that about 70% of contacts had a positive tuberculin skin test. And the staff used that test to persuade the patients to take treatment, particularly when there is side effects like musculoskeletal symptoms or having to remember to take treatment every day for 6 months. it's really important that patients believe that they have a condition. And so I think from our experience in VQueen, it was very valuable to have done the tuberculin skin test to get high completion rates.
Okay, thank you for that comment. So any other questions or comments?
May I come in? I'm Dr. Nishant from India. There was a question for India. Am I audible?
Yeah, you are audible, Dr. Nishant.
Yeah, thank you. So I think I have a session where I'll be talking about the country experience of programmatic implementation of TPT in the context of DRTB patients. So I'll try to answer that question in that presentation. But just for the moment, we made a introduction of TPT in context of DRTB was introduced in 2021, and there are learnings which I will be sharing in my presentation. So I'll do that in the due course of time. But then I'll be talking about what the experience was in the states where quinolone resistance was not high, and why we chose those, and what is the current coverage, what the experience was. In the interest of time, I think I'll use my time during my presentation. Thank you.
Yeah, thank you very much, Dr. Nishant. So we still have time, so I will be happy to discuss as there is time. Okay, Dr. Kato.
I'm Dr. Kato from RIT Jeddah. I have a question for the treatment regimen for preventive therapy, especially in the country or area where the isoniazid resistance is very high. So we have many people coming from Vietnam or working here, working in Japan. So I'm just wondering which regimen you are recommending for preventive therapy.
Okay, thank you very much. So maybe we'll go to our WHO colleagues. If any one of you can, the Vietnam colleagues. Yeah. Dr. Wa.
Yeah, in Vietnam, it's for the people who come to work in Korea. Test TST for testing for tuberculosis infection, and this is also is one step of the screening out the TB. This is we collaboration with the Japanese for some of the organization can have a quality for implementing the activity, and this is in National Lung Hospital. And in our country, this is for general we still follow the WHO recommendation up to now. This is for the household contact for children under 5. People living with HIV is no need for the skin test, but for the other, we use the TST, tuberculosis skin test, for the household contact, and or they are preventive using levofloxacin. We collaboration with World Cup to implementing successfully the VQueen study in Vietnam, and we have put the levofloxacin for preventive for the contact of MDR-TB patient in the guideline. However, we have planned for implementing, but still it's not yet. Because we need to procure and for some of the process for put it in the system. I think. Thank you.
I just want to know that which regimen you are using for the people who has not yet identified as a case for which index case is MDR. I mean, generally speaking, your isoniazid resistance is very high. So if you give the isoniazid alone, about 20% or something are not effective.
Yeah, in Vietnam, it is you're right that the prevalence of the isoniazid resistant among the TB case around 19%. It is according to the DST number 4 we conducted in the year 2011, and currently is estimate is around 20%. Up to now, this is when we identify the people is in the group is identified is resistant with NH. We use the regimen separately for it's a levofloxacin 6 months. This is for the people with NH resistant. It's maybe Dr. Huyền will adding for this one.
If I may comment regarding the question of the isoniazid resistant TB, H. monopoly resistant patients in India, what we did under that policy, we have initiated them on 4 months rifampicin, and the treatment completion rate among about 2,500 contacts of H. monopoly patients was about 79%. But there were operational challenges in evaluating after putting them on the preventive treatment that again I'll be talking about in my presentation. So in India, H. monopoly resistant patients, we tried 4 months rifampicin. That's just wanted to share that.
Okay, we can have one more question or comment.
I just want to ask something for the question from Dr. Shako.
Yeah.
He asked in Vietnam, because of the high proportion of the H isoniazid resistance, so what regimen we use for TBT? In Vietnam, so far we use mostly 3HP and 3HR. And in the new guideline, we add for 4 hours and 6 levofloxacin for MDR-TB context. However, we still use 6H for the contact of the sensitivity TB, and also for high risk groups. But mostly we use 3HR, 3HP for the TBTs in Vietnam. Only the case have the contrast indications with the 3HR, 3HP, we have to consider 6H.
Okay, thank you very much. So, and yeah, we will move now to the next activity. So, and here we are going to have a group photo. Then after that, we'll move to coffee break. So then we'll come back for the other session. Okay, thank you very much. So, and maybe for the group photo, we'll move around the stage and use the stage for it. And if you can please come in front. Thank you. Maybe can you please come around?
Back lower.
Lô 12.
Good morning. Just checking whether my screen is visible.
Hello, everyone. Can we resume our session?
Good morning. Just checking whether my screen is visible. Okay.
Just hold on. Okay, let's start. Let's resume our session. Yeah, please be seated. Please be seated. Okay, okay, let's start. So from now on until the lunch break, we have 5 presentations in line, and then we'll listen to presentations first, and then we'll have a time for overall discussion, and then until the lunch break, and then per presenter we give you 50 minutes, and then so also we have some signboard like this, and then so we'll show this signboard, and then according to the remaining time, and then like this. So I'd like to introduce the first speaker, Dr. Nishan Kumar, who is Joint Director of the Central TB Division under Ministry of Health and Welfare, India. So he will present 2 topics. And the first one is country experience of the programmatic implementation of TPT for context of DR TB patients. And the second one is country experience on access and use of this possible formulations of the isoniazid and rifampicin for TPT among children who are contact of TB patients. So Dr. Nishan is online. So that over to you, Dr. Nishan.
Thank you, Chair. And again, good morning and namaste from India. Thank you for giving us this opportunity. Wanted to be there in person, but I have to do virtually for today. Since morning we are hearing about accelerating the policies which have been brought about and the evidence which has been generated to make gains what we lost in during post COVID and all. So most of the countries have bounced back. So today's topic is our experience for programmatic implementation of TPT for contacts of DRTB patients. So, and I think the second topic given to us is our experience on access and use of dispersible formulation of isoniazid and rifampicin for TPT among children. So I'll start first with our experience with the implementations or programmatic the implementation of TPT among contacts of DRTB patient. So I'm just trying to move my slides. So if Right. So, the program has always in 2016 onwards, there was a strategic plan laid out, thoroughly thought, with the four major pillars of detecting early, correctly, so that we can put them on right treatment in shortest possible of time. And of course, there was a component of prevention of TB infection, so that the breakdown to disease and recurrence, we can make a dent on that. So very well articulated in the national strategic plan, and we last 7 years we worked on that and gained success, which we would like to share today. Also, the component of building supportive systems and policies, building partnerships, building the health infrastructure. And today also in the morning, one of the colleagues said that we have to involve the general health system. So building partnership across the different health programs, and going beyond and multi-sectoral, strengthening and whole of government's approach, because it is a global emergency. So under the NTP, National TB Elimination Program, there are three parts under which the prevention is covered. One is the programmatic management of TB. So of TB preventive treatment, and vaccination is important component which is given at birth, which prevents from complications of the infant to have developed complications, or so that is there. We also tried, because so far whatever evidence was generated, program has tried to imbibe it, and because we committed that we have to achieve the SDG goals as soon as possible, or in the shortest possible time. So whatever was there in the hand, we tried, and we tried to generate some evidence for BCG vaccination in adult group as well. We are we will come out with the evidence which we generated. And of course, the important part of prevention is always has been airborne infection control. The guidelines are there, but how they are followed is differential in the country. But COVID has taught us how it can be done when people have learned to wear masks. The AIC guidelines under the TB program in India has been talking since 2010, but the implementation again was differential. And we have taken especially post COVID, to ride on the momentum gained during airborne infection control. The behavior which we acquired, or we were forced, if I may say so, that COVID has taught us, to wear mask, and again making it an making AIC institutionalized in all the healthcare settings. I mean, before the patient comes inside the hospital premises, that has to be put in place. So that is also a very strong component, and the right time for India, because from 2017 to 18, the gap of missing cases have in India has been able to successfully reduce that gap to just about 0.1 million, which was about a million in 2017-18. So year after year, in spite of COVID, we bounced back and we reduced that gap. So we made a plan, and I'll talk to that policy decision which we took in 2021. But before that, just to give you the national TB preventive treatment policy which the country has. So basically, under the NTEP, there are three target groups for groups for TB, PLHIV. They are, eligible for 1 HP and 6H regimen. Household contacts of pulmonary TB patients and other groups are eligible for 3 HP, 3 RH, and 6H. And for contacts of DRTB, the TPT treatment options are we tried in 12 states and for with the levofloxacin, 6-month levofloxacin, where the quinolone resistance was relatively high than the national average, and of course the 4-month rifampicin for H monopoly. So as I said, when we started implementing the NSP in 2018, the policy was for TPT was only for PLHIV and contacts who were less than 5 years old with 6H. This was the policy in 2018. And in November 20 and early part of April, started piloting introduction of TPT with 6H and 3H regimen. And then with the results, we made it a policy and came up with guidelines for PMTPT, programmatic management of TB preventive treatment. And we introduced TPT in context of DRTB into 12 states, where relatively the quinolone, resistance susceptibility was better than the some of the high burden states. Then in Jan to July 22, it was rolled out in 194 districts and a phase scale up in the rest of the districts to have the learnings how it is faring, and then to scale. India as a big country, and so we started, and from the learnings we get at each we took a deliberate review and then took it, and then piloted the introduction of 3 HP. In August to December 22, then by the learnings of the earlier experience in those states, the recommended scale up of integration of TPT at risk groups during ACF was also introduced, and by the experience and by evidence which we got, the government went ahead, the ministry went ahead and we procured 5 million courses of 3 HP, and at the same time TB antigen skin test SciTB locally made, indigenously made was also introduced, and to increase the uptake or to make communities ready, or the practitioners or health practitioners, we also incentivize the frontline health workers who would get the contacts of TB patients to put on TPT. So that incentive for the health worker was also institutionalized. And last year in October, we complete transition of 3 HP in household contacts at risk individuals, which was completed. And of course, it was there were some recording issues. They still exist. We are working, and but it is recorded in our electronic case-based system. And then 1 HP for PLHIV was also done, and so with that experience, I mean, in those 12 states, which I will show in the next slide, where the enough lab capacity to do the second line LPA and DST for the index case was there. We rolled it out there. And from those learning, 4 more states have also, the numbers are small in those numbers, in those states, but they are also, procuring the levofloxacin and putting it to use. Of course, malnourishment is the biggest driver of tuberculosis. So nutritional support to household contact was also I mean, it was the provisions were made that the patient, the family of the household, the TB index TB patients should also get the nutritional support to increase the to reduce that transmission and breaking out of TB by improving the nutritional status of the people living with TB and people around them. So, so what are the options which are there under the program? So we have the traditional tuberculosis screening test, IGRA, and now indigenously developed antigen-based skin test, which is there. And the recommendation now is testing for TB infection if household contact is more than 5 years, and other is integrated with ACF. I'll be talking about the other risk groups also in detail. And the implementation was in-house testing or end-to-end services, and the states have been given. If I may call it a cafeteria approach, that these are the tests which are available for testing for TB infection. So as per their experience, as per states competency and their readiness, these are the three tests which are available. This was the SciTB was incorporated into the testing for TB infection after the body which is responsible for research in India, that is in Council of Medical Research, they conducted an efficacy and safety study of SciTB. And after due regulatory approvals, and we procured about 5 million test doses, and the capacity building is being done, and it is being done through the general health system approach, and the mechanisms, the provisions are made so the entry is reported and recorded in the electronic case-based system. So what was our experience during of these testing? Variable positivity between IGRA and TST because of non-standardized TST and variable reasons. So there are issues there. There are there are questions from the field and some hesitancy, and the training and skill required and healthcare worker for anything new which comes in. I mean, to train the frontline health staff across the length and breadth of a country like India is one challenge. But then the uptake is really is encouraging. I think 39% of the CYTV has been already consumed. Leveraging the health system, and for as I said, that whole of government's approach, that is the principle which we are following, and that has been our experience. A word about TPT in household context of DRTB, our experience with. As I said, when the policy was made in 2020, it was that to be initiated in limited geographies to gain experience, and first was contacts of MDR-TB where fluoroquinolone susceptibility was there. And for MDR, it was 4 months of rifampicin. Strategy was testing for TBI and TPT after ruling out the active TB disease. So that was incorporated in the document, in trainings, in discussions. So that message was very clear that we have to rule out TB first, active TB first, and then it should be put to use. So it was a very deliberated decision to how to scale up to the whole of to all the states. That first it was an informed decision of National Technical Expert Group. Lot of discussions happened that how do we scale it up. And then we identified the geographies, and then made the logistic requirements, including the capacity building and administrative approvals for resource allocation. And then, of course, regular refresher training, reorientation through virtual trainings and physical training as well. And most important thing, you can introduce a new intervention, but then the regular supply is the foremost and very important part. So we maintained that the program maintained the regular supply so that after the states and districts, take it up, we should not be found wanting in terms of shortages or those things. So that was taken care of. And allocation of entire course or to the treatment supporter as well, so that it is as I said earlier, it was a policy decision to incentivize the treatment supporter, and then of course the recording and reporting of the intervention. So as I said, it took to because a message should be very clear when we introduce a new intervention. So it was in 12 states that these are the states where the fluoroquinolone resistance proportion was lesser than the national average. Yes, the states in the middle where the TB burden is high, but so is the quinolone resistance is quite high. So it was started with the states where it was relatively less, and there was adequate laboratory capacity, and we decentralized it to the district DRTB centers, and the capacity building was done up to district level. And it was also to coincide with scale up of shorter oral BDQ containing regimen for MDR-TB. So overall, it was very well thought of and very deliberate scale up. So there was a question about coverage and outcome of the country's experience. So from January 22 to 2024, about 3,534 contacts of MDR patients were put on 6 months of levofloxacin preventive therapy. So 89%, and this year on year, so this is the data for 23, but earlier also, and in 2024, we are still analyzing. The completion is quite satisfactory, as was highlighted by Avinash in the morning also, that there are no major issues there. But yes, there are challenges, operational challenges in the field, especially a vast country like ours. And it was. We had issues with the evaluation, which was a lot of reasons added to it. The patients migrate from state and districts, making it difficult for the program to trace them. There are some data entry issues as well, which, when the outcomes were not reported. So we are sorting those out, and what if we so these are the how do I say, it's been 2-3 years, but still these issues are there. So working on those, and regarding the for the rifampicin, preventive therapy for 4 months, rifampicin preventive therapy for H monopoly. So this is the data again for 2023. Again, the completion rate is about same across the years. But again, those issues of same issues of migration, data entry, that is we are working on. But the overall decision is that now it is being will be scaled up. Levofloxacin is in MDR-TB context of MDR-TB. Levofloxacin is the states are picking up. So this is the experience which I'll summarize it in my last slide, that anything that this is a normal human nature, where anything new, the acceptance, both in clinicians, community, and the program managers, there are we have to work that. So it required multi-pronged advocacy, specific education material, and science given in basic understandable languages, that why it is important, that we are still working. And I think in the parallel session which is going on today, these issues are taken, and India has actually institutionalized this component of getting the community on board, while we make policy so that the community members, civil society, TB survivors are part of our expert groups. They are part of national TB forums where these informations are shared so that it is accepted in the community. So it is challenging. Everybody, I mean, the epidemiology of the disease is such that we are struggling with completion and adherence issues with the TB patient. So giving someone medication who do not actually have active TB is a challenge. Not that easy to answer. Yes, we try our best, but I think taking the communities along and making it a felt need, why it is important, is something which we are working on. And I think the parallel session is also should be talking about it. Then the role of second line drug susceptibility testing, expansion of fluoroquinolone testing coverage, as I said, is in index, MDR TB patient would improve access to the 6 months preventive therapy with the levofloxacin. And provisions are made when we say resources. So states are budgeting it there in annual plans and procuring their own. And centrally also we have in a process so that there is no shortage of the supply and adherence monitoring. Again, I've shown you the data that high completion rates depend on community involvement and effective adherence monitoring tools. So yes, because there was a lot of energy, lot of in the initial pilots and initial when we start a new thing, there is a lot of energy, but then it has to be maintained by ownership of the district level or below district level program manager implementers. So that's what we are working on. And as I said, provisions are there for the frontline health workers. So in addition to training them and why scientifically and why as a public health action it is very important, we are giving them incentives as well. So program is, as I said, leaving no stone unturned. But the challenges which are there with preventive therapy are a lot of work has to be done there. Ruling out active TB, easier said than done, because we have tried in last 100 days. We launched a special campaign to see how, because now is the right time. As I said, we have almost bridged that gap of missing TB cases. Most of them were symptomatic. So now the program in the last 100 days was actively searching for asymptomatic TB, screening asymptomatic vulnerable populations identified in the country. And that is the way forward with the countries, countries founding the estimated numbers, getting them under their net year after year, plus screening the asymptomatic vulnerables so that we can put them on treatment if TB positive, or put on TPT. So that was one exercise which we analyzing the data of last 100 days. So there were issues like the capacity for giving X-ray as a screening tool, even with handheld, to all the vulnerable populations. And going beyond asking for symptoms and actually screening them with X-ray or I'm really looking forward to see what more screening modalities which are in pipeline. So yes, ruling out active TB is very, very critical to scale up the TPT. Digital infrastructure for monitoring. I mean, without this, I mean, this is again a very important and we have the system in place, which is quite robust, but the data entry from the field level, which is an area which we are working on, and again, as I said, if you've seen in my presentation earlier slides, every 6 months we took a review where what we did, what we yielded, and how cost effective it was, and then we went ahead. So this is all from our side for this topic. And regarding I'll finish the other presentation because the country, the second topic given to us was the country experience on access and use of dispersible formulation of isoniazid and rifampicin. So as of now, what we have is dispersible isoniazid 6 months, which is available, and it's being used, and private sector is somewhere, clinicians in private sector is where we are working on to increase the uptake. And so this currently we don't have 3 HP in dispersible form in India. But yes, we are watching other. We would like to hear from other countries how today. But as of now, our coverage of dispersible 6H is about 60%. So this is all from our side. I'll be happy to take the questions. I mean, India may consider procurement and use of dispersible formulation, or if some donation to for a pilot, we are they can reach out to the program. With this, I think I'll stop here in the interest. I hope I have done justice with the time limit.
Okay, thank you, Dr. Nishan. And then, can you stay over this question?
Yeah.
Okay. So I think for now, let's move on to the next presentation, and then so we'll take some questions on your presentation later. Okay, thank you.
Thank you.
Okay, thank you very much, Dr. Nishan. So we'll move to the next presentation. So, and it's about asymptomatic TB and programmatic implications. So, and then is Falson. So we have a pre-recorded presentations with this.
This presentation abbreviated as the work of TB in the development programs. To also briefly the WHO research needs of what is the first few aspects when those emphasizing what people using single labels and even presenting tests such as this particular program. The entity stretch will be but it's also very but ATP is a condition that TB spread cells. As these activities expand, there was a serialization of non-mediated disease, which eventually allowed the person is disease. Has been suspended again The number of people with TB reported or diagnosed or even show physical signs of the TB. Historically, WHO TB definitions of between symptomatic and asymptomatic disease. This makes it difficult to have a common understanding of asymptomatic TB. Common definition can help surgeons guide the diagnosis. Defining asymptomatic TB will also see as program. Even though the definition may be used in quite symptoms, many TB programs still report that they notify and treat. In recent years, attempts have been made to define TB primary medical research areas. In early 2024, the International Consensus for Rare or ICD published a definition research agenda for AD. Individuals suspected were described as those who are about to aware or do not record instances during the symptom screen or maintenance that have no physical sign that would be recognized as the tuberculosis or clinical examination. WHO convened tests in October 2020 to discuss the relevance of current knowledge of AD to program application and decided a cognitive definition would be feasible in that use. Participants of the consultation included national TB programs, academic groups, technical agencies, civil society, funding partners. Participants of the WHO submitted definition is subject of set standard WHO study for TBs released in area showing the study. There will be subject of data development over specialists shared experience or better over which is currently very AD subsequent person believes reports suggestible TB. The important the AD and the stage should weaken the very development the course of before the study versus also must be declared that the person has a disease and not just TB infection. This is made on the basis of bacteriology, imaging, or histopathology. Two subsets of the ATB definition, categorized as bacteriology confirmed and unconfirmed, are shown on this slide, alongside the corresponding existing TB surveillance definition. Thus, people with TB would be stratified by both symptoms and bacteriological status. This slide highlights some of the key characteristics of the TB patients in each of these four subdivisions. Symptomatic TB is the most common form of TB that is notified, mostly through passive case finding, and bacteriological tests are most often used to confirm disease, although not all people who are treated for TB will necessarily have a positive test. Detection of bacteriologically unconfirmed ATB relies upon patient history and imaging and histopathology findings, and may require follow-up testing to diagnose. The increased recognition of asymptomatic TB has a number of implications for current WHO guidance on TB. The definitions of ATB will be integrated into the TB surveillance guide, and the data elements required to classify a notification as symptomatic or ATB defined for individual level reporting. In the area of infection control, there will need to be consideration of ATB in respiratory separation practices within the limits of what is possible. This also raises the importance of early detection and treatment of ATB. Rule-out algorithms that are commonly based on symptoms will now need to assess the potential for people with ATB among those who are considered eligible for TPT. The infectious potential of ATB will also influence whether TPT recommendations should be extended to contexts of an ATB index case. A screening algorithm which only refers for clinical evaluation those individuals who are symptomatic will now need to be evaluated in light of the risk of missing ATB. Revised estimates of the contribution to transmission of ATB cases in the community will have a bearing on the TB prevalence threshold used to recommend community-wide screening. Insofar as diagnostics are concerned, ATB opens questions about the algorithms to use to detect it in children and adults, and about how to diagnose bacteriologically unconfirmed ATB in particular. One key question will be the role of tests of TB infection in the diagnosis of ATB. Guidance on the treatment of ATB would need to wait until trial data become available. In the meantime, ATB is treated as for symptomatic disease. As part of the consultation, meeting participants also ranked research needs by order of importance. The biggest current needs were felt to be in the space of diagnosis, followed by studies of transmission, treatment, and operationalization. Topmost among the research needs were the impact of ATB detection on TB epidemiology, TB screening strategies, diagnostic reference standards, and optimal treatment approaches. The main findings from the consultation, including the definitions, were released a few weeks after the meeting as part of the Global TB Report of 2024. A more detailed account of the discussions during the consultation can be found in the full report shown here. Finally, I would like to thank the many contributors to these slides, including WHO colleagues, participants of the WHO consultation on ATB, and the Bill and Melinda Gates Foundation and other funding partners. Thank you for listening.
Yeah, thank you. And so I'd like to introduce next presentation, topical issues and forthcoming updates to TB screening recommendations and implementation guidance. This will be presented by Dr. Cecily Miller, and who is a technical officer with the Global Program on TB and Lung Health at WHO. Yeah, over to you, Denise. Sorry, over to you, Cecily.
Hello, everyone. Thank you. And I'm pleased to speak. Are these the correct slides? Or do I click to advance? Oh yeah, here we go. Okay. I'm Cecily Miller from the Global Program on Tuberculosis and Lung Health. And I'm very pleased to speak to you today on the topic area of screening. So I'll just give a brief reminder to us all of the importance that screening plays in global TB care, and briefly remind us of our current recommendations on screening and how they fit into TPT and prevention. And then I'll briefly go over some upcoming updates coming in the area of guidance, implementation guidance, and other areas around screening. Oh, okay. So as a reminder, we discussed this morning, but we all know that globally we are not on track to meet our goals for the NTB strategy. And just to call out a few areas that are particularly of relevance for screening, we have a higher estimated incidence than ever. And globally, while we last year notified more cases than ever, estimated at 8.2 million cases globally, we're still falling short of our total global estimated burden. And that's despite doing more than we have ever done before in terms of finding all the cases that we can. So it's going to be very hard to keep up this momentum unless we can introduce some strategies to really reduce the global burden overall. Additionally, we've also mentioned this, that we're not reaching our TPT goals quickly enough We need to enhance strategies to help us find and start more people on TPT that could benefit from this. And just a reminder that we know from cost surveys that over half of patients with TB who we find with TB face catastrophic costs due to the diagnosis and the treatment and the disease itself, to say nothing of the patients that we don't find. So screening is one really essential strategy that can help us impact some of these catastrophic outcomes. So some challenges to finding all the cases that we need to find. One thing we just heard about from Dennis is asymptomatic TB. So we know from prevalence surveys and other screening surveys that are not gated on symptoms that perhaps half or more of people with bacteriologically confirmed TB don't feel the symptoms or don't report that they feel symptoms. So we know they are not going to come on their own to get diagnosed to health facilities. We also know that even once patients do experience symptoms and go seek care, they face a very long and complicated pathway to finding that care. This is from one study that was done in Uganda. There are several other studies that were done in India and many other countries. So we know that this is a problem globally. So systematic screening can help overcome these challenges. First off, it can help protect individuals who have TB or at high risk of TB. We see evidence that it can help improve treatment outcomes, improve time to diagnosis and treatment, and reduce costs for patients. Importantly, we see evidence that screening can reduce risk of catastrophic costs. We also know that at the community level, TB can help epidemiology. It can help increase detection, thereby reducing transmission and hopefully future incident TB, averting that. And it can help prevent TB entirely by helping initiate preventive therapy among people who are at high risk but don't have TB at the time of screening. So we have guidelines. They were released in 2021, so they're not new now, but hopefully we'll have even more guidelines coming out in the future. Just to remind us, we have two main types of recommendations in our screening guidelines. We have who should be screened and what tools can be used to screen those individuals. And I also just want to highlight that within this one set of guidelines, we're covering one intervention, which is screening, but it can be used for two different objectives. And I just want to flag this now, that screening can be done to protect individuals at high risk of TB and to help those with very high risk, basically improve their outcomes and reduce their risk of getting TB or of having bad outcomes from it. It can also be done to reduce community burden of TB. But in order to achieve these two objectives, it has to be done in slightly different manners. So I think we have to keep this in mind. So just briefly to go over our current recommendations, we have 4 risk groups in whom screening is strongly recommended. And this just means that it should be done everywhere in all global regions, always, basically. So we have screening recommended for household and close contacts of people with TB, people living with HIV, prisoners, and minors exposed to silica dust. We also have recommendations for 2 groups of children that are subgroups of those previous recommendations. So children living with HIV and children who are contacts should also always be screened. We then have conditional recommendations. So these are areas in which screening can be done, but it really depends on the national context and it requires prioritization, okay? So the guidelines don't have an expectation that all countries are doing all of these. There really needs to be targeted to what is appropriate for a given country. So we have on the left recommendations for facility-based screening, sometimes called intensified case finding. So this is in areas with moderate or higher burden. Screening can be done in facilities among people who have risk factors for TB. And this is really essentially a very efficient way of increasing your case detection. People are already coming to a healthcare facility. Perhaps they're not seeking care for TB specifically, but they're sort of in the catchment area already. You can increase detection among people who are already in the door. And we see oftentimes there's a very high yield of this type of screening. There's also on the right, we have community-based screening, often called active case finding. So we have recommendations that this can be done among groups that have high risk for TB. So we sometimes call these people who have sort of structural risk factors. So communities that have higher risk for TB and limited access to care. These can include urban poor or slum populations, homeless communities, refugees, migrants, or any other vulnerable and marginalized group to which this applies in a specific context. And lastly, we have a recommendation that community-wide screening can be done in settings with a prevalence of 0.5% or higher. And this is based on a trial from Vietnam showing evidence of impact on reduction of prevalence and transmission. But again, and I just flag it at the bottom, prioritization is needed. Countries will not be able to do all of this everywhere all at once. So you need to determine which are the priorities for your setting. Then we have some tools that are recommended. So the updates from our last guideline include our more advanced, accurate tools. So at the top, we have recommendation for chest X-ray and a recommendation that computer-aided detection software or CAD software can be used alongside chest X-ray to screen all individuals aged 15 years and older. We see that chest X-ray is a very accurate, one of the most accurate tools we have for screening. And importantly, it can detect asymptomatic TB. It can detect TB in the absence or perhaps before the onset of symptoms. Symptom screening is still recommended. We know it has its limitations, in particular with regard to asymptomatic TB. But it is a tool that's available to be implemented in any setting, very low resource requirements, and it's able to be repeated often. And then we have a recommendation that rapid molecular tests can be used for screening as well. We see evidence that their sensitivity is a bit lower in the screening context, but they do still have very high specificity, which has gains in terms of future diagnostic testing required. Specifically for screening of people living with HIV, we have a similar profile of tests, but we also have a recommendation that C-reactive protein, or CRP, can be used for screening within this population. And this provides additional specificity for screening oftentimes in this population. And this is a really, this is a good development to have this basically a biomarker test that can be conducted on a finger prick of blood. So this is an exciting development as well. And then lastly, for children that need to be screened for TB, we are lacking some of the more newly developed tools. Hopefully we see evidence that these can be used in the near future. But for now, we have recommendations for symptoms and chest X-ray among contacts. And we hope that, again, that we see, for example, the development of pediatric CAD products in the near future. We're watching that space, but they are not currently recommended, as the ask in the pediatric population is different from the adult population. So some updates to be aware of and looking for on the horizon. So in January of this year, we had a technical advisory group meeting looking to evaluate basically the newest selection of CAD products. We evaluated them for the guidelines in 2021, but since that time, there's been a lot of new development in that space. New products have come available. Existing products have new updated versions. So we had a technical advisory group evaluation of currently available CAD products who requested to be included. The results should be available this month, later this month, so please keep an eye out for that. We also have some new target product profiles for screening tests coming out this year. And this is an update from our previous target product profiles from 2014. So again, it's quite an update. It's been quite some time since then, so please keep an eye out for that. And then we'll be looking for new guidance as well. So the first to come out really will be operational guidance. I'll speak on that in a minute. And then we're hoping that in the near future, we have, again, as I said, more tools for screening pediatric populations, and perhaps even looking to the ability of CAD to be used for screening beyond just TB, because we know this is the most important use case really when it's put in practice. So I'm going to briefly now go over the operational handbook as well. This is designed to help implement our screening guidelines. It has several components. It mentions the principles of implementing high quality screening. I won't go through this in detail, just to say that There's an emphasis on maintaining high quality TB diagnostic and treatment services, not to sacrifice those in the name of doing active screening, and synergizing with other health services, following established ethical principles for screening, and prioritizing risk groups and algorithms. The operational guide has a cycle for developing, implementing, and monitoring and evaluating screening, with some detailed descriptions of how this can be done to make sure that the program is having its intended effect. We have some descriptions of different models of screening depending on which risk groups are being targeted and which tools are being used. And we have some screening algorithms. So in brief, we have 4 main types of algorithms, which are just different ways in which screening tools can be combined with diagnostic evaluation. And these can be put together in slightly different ways depending on if the goal is to maximize the sensitivity of screening, or if the goal is to have the most efficient screening algorithm, for example, to help ensure efficient use of diagnostic testing or cartridges down the road. So we have 4 different algorithms total. I'm not going to go through them in detail here, but they can be found in the handbook. Feel free to ask me if you have more questions. We have a brief description of monitoring and evaluation for TB screening. Avinash mentioned the importance of this for TPT. We also emphasize it here for screening, the importance of capturing the cascade of data while screening is implemented. And this allows for evaluation of, we often call them sort of programmatic indicators, or implementation indicators on the right here, which basically help you understand how the screening program is being implemented, if it's having its intended effect, if it needs to be adjusted. For example, if the screening test is not sensitive enough, or perhaps it's too sensitive and you're having too many people screen positive. If you are engaging people in care all the way through, or if you're losing a lot of people after the screening step, things like this can flag if certain elements of the program need to be adjusted. And then lastly, there are indicators that you can look at in terms of population level impact to see if screening is having an impact on, for example, reducing your burden. So lastly, just to flag, we have, for example, here the Screen TB tool, which is an online tool to help countries design their screening programs. It's a sort of an early stages program planning tool to help countries evaluate perhaps what risk groups can be prioritized and what the possible effect or sort of outcomes of different screening algorithms might be. This has been updated to include quite a bit of country-specific data now, including estimates of country prevalence of TB derived from our global TB program data, and country-specific estimates for unit costs for screening and diagnostic tools. So hopefully this can be of use to countries. Again, this is for early program planning, not very detailed budgeting. We have other tools for that, like the One Health tool. And there will be more updates coming to this as well in the future, including new diagnostic options based on our updates to our diagnostic recommendations. So lastly, things coming soon in the operational guidance space. So we're working on, with colleagues in MSF, on a pragmatic guide to CAD calibration or threshold selection. We know this is a very important aspect of implementing CAD for screening, but the current guidance we have can be very difficult to implement in some areas. So this alternative will provide what we're calling a pragmatic approach to be able to quickly evaluate if the CAD threshold that you're using is appropriate or not. So watch the space for that. And then in general, we will be updating our operational guidance on screening this year to include further guidance on facility-based screening approaches, community-based screening approaches, and tools and algorithms, including, for example, best bet algorithms for different screening interventions. So with that, I will thank my WHO colleagues, and I thank you for your time, and I'm welcome to take any questions.
Thank you very much, Cecily. So we'll move to the next presentation. So, and this is experience of AI CAD for screening in Philippines, Cambodia, Nepal, and India. So, and it's presented by the Director of Japan Anti-Tuberculosis Association, Dr. Seoka.
Good afternoon, everybody. It's my great pleasure to share the experience of AI CAD for screening in the Philippines, Cambodia, Nepal, and India. As was already presented by the Cecile right now, the use of AI CAD screening is already recommended by WHO. So first, I'd like to talk about the experience of AI CAD to enhance screening at the health center level in the Philippines. A flat panel detector was installed in the existing analog X-ray system at a health center. First, they interview the visitors to check the presence and duration of the symptom. Based on these results, they performed X-ray examination using CAD as well as using CAD. And sputum examination with expert was conducted by the result of CAD score and radiologist interpretation. Among 1,626 clients with more than 15 years old, 1,582 clients screened for TB symptom. However, out of these number, only a total of 481 clients underwent chest radiograph with CAD assessment or CAD assessment. Among these, 382 clients was classified with CAD score of more than 15, which is as a suggestive TB, and 120 clients underwent expert testing, and the result confirmed 21 TB cases. And out of 481 who underwent X-ray, finally 24 clients were enrolled in the treatment. This is a discussion from this study. The installation of the flat panel detector and CAD in existing analog system was worked well for TB screening in a health center. The digital radiography offers the advantage such as high resolution image, streamlined workflow, and remote diagnosis capabilities. The intensified case finding with AI CAD contributed to early detection of additional asymptomatic client compared to the conventional passive case finding approach. Participation rate for X-rays with CAD and gene experts testing was only 32.6% and 31.4% respectively. Analysis suggested that gender, economic status, area of residence, stigma, and lack of knowledge about TB influenced participation. An interview to the client revealed that difficulties with sputum expectoration, burden of a visit, on transportation cost, and lack of a perceived needs as a barrier. Next, I will share the experience of examining newly developed AI CAD from Fujifilm Corporation. FCAD was a retrospective AI CAD named FCAD was retrospectively examining using the data set of 386 chest X-ray image and medical data of the participation from the community-based AIDS active case finding in 13 districts in Cambodia. FCAD was developed as a prototype of Fujifilm Corporation. Target population is a person aged 15 years old or older, a person with any TB symptoms such as chronic cough, and persons at the risk of TB, including household contact. With the reference of TB expert, positive TB and interpretation by experienced chest physician, ROC curve was drawn to evaluate the performance of AI CAD. This panel shows the IQR of TB scores by classification of human readers for chest X-ray and the score of the FCAT was significantly associated with the result of the human reader for chest X-ray, as indicated by the severity of TB diseases. This panel shows the ROC curve of TB scores with a bacteriological reference, as well as the sensitivity and specificity basis on the classification by the human reader. Area under ROC of FCAT was 0.866. And when we compare the area under ROC by age group, the area under ROC curve for those who aged 65 years or older was significantly lower than those aged under 60 years old, although it was not shown in this figure. From the conclusion of this product, AirCAD is applicable to community-based active case finding in high TB burden setting, where the experience of human readers of chest X-ray image are scarce. The use of AirCAD in the American country has the potential to expand chest X-ray screening in a community-based active case finding with a significant reduction in human readers and laboratory workload. Next, I would like to share the experience of a project called Strengthening Urban TB Project in Kathmandu metropolitan cities by active case TB case finding. The target areas, 8 out of 22 urban health clinics with TB case load and higher number of risks and vulnerable populations such as factories, slum, and congregate setting. Ultra-like X-ray, AirCAD, TB lamp, and expert was used in this project. This is a collaborative study with Jantra, that is a local NGO funded by Global Fund in collaboration with the Kathmandu City Office. This is a picture showing how portable digital X-ray was used in this project. This panel shows the algorithms for this project. It's very busy, but I just explained the summary. The target population is the people who are 60 years old or older, regardless of symptom. Chest X-ray was done first. And if it shows active case finding or suspected TB or old TB with TB symptom, TB lamp was done. If the result of the TB lamp is positive, gene expert was done to check the rifampicin resistance. If the result of TB was negative, clinical evaluation was offered to identify the cause of chest X-ray abnormalities. Active case finding in slum area reviewed 8 TB patients from 348 participants, showing yield of 2.3%. Sorry. Oh. In the boarding school, 8 TB patients was detected out of 684 participants. Considering the target population was young, the lead of 1.2% is very high. As a conclusion, active case finding with chest X-ray in community-based setting is effective, especially for asymptomatic patients, both bacteriologically positive and negative TB. The combined use of TB lamp and gene expert for a proposed algorithm of active case findings practically efficient, as TB lamp is high throughout, while gene expert can test for rifampicin resistance. The last but not least, I would like to talk about the Fujifilm and JADA collaboration screening initiative, which is supported by Ministry of Economy, Trade and Industry of Japanese government and other agencies listed in the top. This project was aimed to screen, diagnose, refer, and sensitive TB patients in Banaskantha and Valsad district of Gujarat in India, where the industry area, mining belt, and surrounding villages, semi-rural area are located. Active case activity included visiting community to invite people to health checkup, and in collaboration with a local district TB officer, leaflet distributed, and a direct contact was made with people to make them aware of the TB health checkup. And chest X-ray was done with AI card using mobile health screening van, and discussion was held at the local hospital to share the result of the screen. This is a screening algorithm proposed to the government. First, participants undergo a health assessment, and those who have any risk are subjected to chest X-ray screening. Active and suspected TB are detected by reading by the results or AI card. And NAT will be done. In this project, we reached a total of 1.6 million people in 2 districts to inform about this health screen. Among them, 41,000 took health risk assessment, and that was done to 532 TB suspects. And finally, 470 TB was detected. This panel shows a summary of these 4 screening. First, in all projects, TB screening with AI card and NAT was effective to detect more TB patients. In the 3 projects targeting community, yield is about 1%, which seems to be good, very good. Maybe it is because the high-risk area of people are selected or risk assessment process was imposed in advance to the chest X-ray screening. Third, participation rate in screening from initial target should be considered because of the possibility of missing TB patient in the In the Philippine project, difficulties with sputum exploration, recall burden, and transportation costs and lack of perceived needs were identified as barrier. Screening with chest X-ray using AI card and NAT eliminates visits between burden and transportation costs. Awareness in TB and stigma is necessary to increase the participation rate, especially in community TB screening. Now, I would like to acknowledge the great effort of the staff concerned to this project in these 4 countries. Thank you very much for your time.
Okay, thank you, Dr. Kato. And then thanks to all the presenters for your excellent presentations. Now discussion time. So we have covered a variety of topics, from TPT for DRTB context, and then also these possible formulations, and also asymptomatic TB, or TB screening, and AI tests. So we have the 2 fixed microphones, and the one microphone, the wireless microphone is moving around. So using the nearest one, please make any comments or questions.
So thank you. I'm Dr. Navin from Nepal. I want to ask some questions about this TPT therapy in India, like DRTB cases. They are started in 12 states, not in all states. Why in the 12 states? What is the percentage of fluoroquinolone in that 12 states where they have started the TPT? And is there any plan to enroll TPT in all the provinces of India where the fluoroquinolone resistance is higher? In Nepal also, we have done the DR survey, and that FQ, fluoroquinolone resistant, is around 50%. Whether we want to go for the same medicines like levofloxacin or want to go for another medicines like delamanid or something like that. And how to measure the efficacy of TPT, mainly these fluoroquinolones in the DRTB, where the FQ resistance is very high. And also, that's all from my side.
Yeah, Dr.
Can I answer that? Can I come in? Can I answer that?
Yeah, sure, yeah.
Yeah, thanks for the question. And yeah, I mean, that's a very pertinent question. I mean, to start with, uh, we excluded the states where the quinolone is, as you said, in your provinces, like 50% or more. So first, we wanted to see. So we selected those states based on two things: that the quinolone susceptibility is better than the national average. So those were the states which I showed in the presentation. If I mean, most of them were the southern states, and with lab backup to get the DST status of the index case. So that is why we, as I said, that though states like Uttar Pradesh, Bihar, Chhattisgarh, they are high burden states, but they were left out to start with because we knew, as you rightly said, that in your country also that is the issue. So first we wanted to see the effect in the states where the quinolone resistance is relatively lower, and then we are uh, as I told, we included those 12 states, but then the four other states where the quinolone resistance was not that big a problem, they also took up. So slowly, that's how we are. Again, we'll take it to the National Technical Expert Group, and we'll scale wherever we can. Yeah.
I want to know that, is there any criteria? How much percentage is the FQ resistance up to which you are going to enroll? And also the provinces like Bihar and UP, which is related to Nepal, do you have to plan to enroll the same medicines like FQ or something else like Delamanid or something like?
No, yeah. So again, in spite of now, the plan is to scale it up to other states also, where the quinolone resistance is to the tune of 50%, that as well. But what we are seeing, the acceptance in the other states where it is slightly lower. But the plan is not to. I mean, it's up to the state how they take it. So the national policy from the central policy is to scale it up to the all state, irrespective of the level of fluoroquinolone resistance in a particular state. Because again, in states also there is quite differential in different districts. The quinolone resistance is different. So there's no restriction on states where the quinolone is high also. But so this experience has the as of now the understanding is to scale it up to all the states, pan country.
Okay, thank you. And any other questions or comments? Yeah, please use this microphone. Yeah.
Hello. Yeah, I have question for Dr. Nishan. Do you have any experiences about including the TB drug for TPT within the health insurance plan? Is this by the project, or is it included in the health insurance plans? Thank you.
Yep. If I understood the question correctly, whether you are saying because of TPT the incidence has gone down? That is the question?
The question is, TPT is covered by health insurance or just project-based TPT is provided?
It's not under insurance. Under the programmatic condition, the TPT is available free of cost. No insurance. I mean, it is available across all the states free of cost. Patient does not have to, or the household contact does not have to pay anything. Even the contacts in private setting, the patient is notified and brought in the net. The household contacts are eligible for free TPT under the program.
Okay, thank you.
Okay, any other questions or comments? Yeah, please.
Yeah, I would like to thank all speakers for their very clear presentations. Yeah, I also would like to start with a question for India, for Dr. Nishan. As you have been using the CYTB test, I was asking myself if you have an idea of the level of CYTB positivity among contacts. We just heard from Dr. Fox that the positivity rate that was with THT and IGRA, if I remember well, among contacts of people with DRTB was, I think, around 40% and or just over, and among people with drug susceptible to be, it was about 28% or so, if I remember the numbers well. So how was that in India, in your epidemic environment and using the CYTB test?
Yeah, as I said, CYTB has been introduced very recently, and we are still analyzing the data, but the initial data suggest, I mean, there is variation across the states. Somewhere it is too early to say, but I'll put my neck out and say 15 to 30% is the range. But then we have to analyze the data because it was recently introduced. Once we have enough, data, we'll be able to comment that on confidently.
Next question, Agnes, or no more?
Hi again, I'm Dr. Navin. For Dr. Miller, I think, Cecil Miller, you said that WHO is going to introduce CAD in screening for the TB patients, and lots of people are diagnosing on the clinically diagnosed cases from the CAD. Is it acceptable or not? And one thing, like sometimes it is overdiagnosis also. You can see in the program sometimes there is the overdiagnosis of clinically diagnosed cases. Definitely there is a cutoff threshold for different countries is different. So before enrolling that, I think we have to evaluate very closely what is the cutoff value for every country or something like that. Otherwise, there will be, like in Nepal, we are using the CAD. Sometimes the score is 90, still the symptoms, there is no symptoms and it is negatives. Sometimes it is 15 and then it is positive. So whether it is good for us to use or something, guideline is coming some different.
Yes, thank you. So to speak to your question, so first off, CAD is recommended as a screening tool, but it is not recommended to diagnose TB. So what we recommend is that anybody who has a positive CAD screening test should go on to a diagnostic evaluation that includes bacteriological testing. If the bacteriological test is negative, sometimes a patient still will be diagnosed clinically, but that would be the result of a thorough diagnostic evaluation with a clinician looking at the complete picture presentation of the patient. It would not be based on a CAD score alone. And yes, we know that calibration needs to be done when these CAD tools are used, depending on the product that's used, the version, the population in which you're screening, perhaps even the hardware that you're using. We see some data that can slightly affect where the threshold should be put. So we have already a guideline or a operational, I don't remember exactly the term, a toolkit for conducting a calibration study to help really determine sort of what we think of as the gold standard for really determining what the sensitivity and specificity of the CAD product is in your setting across any possible threshold you use. And then you can determine exactly where you want that to be. However, if that's not available to you in terms of the resources you have for this, we have another alternative guide that we're coming out with right now. Well, colleagues at MSF are developing right now. We're working with them to give pragmatic guidance on how to, in a very sort of efficient way, quickly determine where the threshold should be when you're implementing a CAD based on the results from implementation, based on a little bit of pre-work and the results as you implement it. So watch the space, that's coming soon. But we do urge people to just pay attention to where that threshold is set, because you don't want to realize that you've been screening with CAD for 6 months and your threshold is way too high and you've missed a lot of potential cases, right? Unrelated to this, I just wanted to flag that we have other colleagues from headquarters online now, Dennis and Avinash, that might be able to speak to these questions about TPT among DRTB contacts and regimens used and use of levofloxacin in high fluoroquinolone resistance areas. So I don't know if we want to let them speak for a couple minutes.
Yeah, Avinash or Dennis online? Oh, not now. Maybe later or. Okay, so Dennis or Avinash? Do you hear me, Dennis or Avinash? Okay, maybe later. I think you can just chat to clarify the questions. And then, so yeah, in the meantime, so any other questions or comments?
Sorry for coming again. I would like to recommend Jata for your elegant studies you've been doing, really showing the feasibility also of using these tools in different settings. Now, I would like to ask you, you've been doing this in Nepal and in other countries, so can you say something about how widely this now has been implemented beyond your the studies you've been doing?
Sorry, and I maybe have a quick follow-on question to that. Thank you for the presentation. I saw in your boarding school presentation, you were looking at that age group of 5 to 14, and I was just wondering how, or if you use CAD in that age group, aware of the fact that the guidance is really for the sort of older adolescent age group, but so how was chest X-ray used in that younger group in the school context? Thanks.
It seems to be a difficult question for me. Anyway, we can expand the use of CAD depending on the situation. We need to consider the restrictive situation, whether, for example, prevalence or area or resource for the variant and other things. But anyway, as we showed, the air CAD is applicable in any situation. And we need to collect the experience of many countries by area so that it's really used for global TB control. And for the boarding school, I had an outbreak happen in the school. So that seems to be a focus of infection in that specific situation. I don't know the detail, but the student in boarding school is teens or any younger generation, but still it's effective to prevent from such kind of outbreak if you introduce the screening, because it's a really conglomerate setting. Do I answer your question? Thank you.
It's okay. Any follow-up questions? Okay, if not, any other questions or comments? Okay, now.
Hi, Kyung. Can you hear us?
Yeah. Now we can hear you. Yeah, please.
Okay, great. Thank you very much for the discussion. and Dr. Nishant for presenting the India experience. And I think I just want to respond to one of the questions from the colleague from Bangladesh about areas with high quinolone resistance and what could be the programmatic actions. So as of now, as you are aware, levofloxacin is the only regimen that we have a clear recommendation on. And in areas with high fluoroquinolone resistance, what we suggest is one, to strengthen the capacity for fluoroquinolone resistance testing. And if an individual is found to be exposed to a resistant strain, then in that case, we don't have an option of providing the levo regimen itself. I covered in, I may not have covered in my presentation, but one of the clinical trials that's happening, the Phoenix trial, we will hopefully receive results by the end of this year, and maybe we'll have another option for TPT. Regards monitoring, it would be similar to the way we do for other TPT regimens, and we look for breakthrough TB and deterioration in any way. So it would be similar to the DSTB way, I think. So this is the only a solution that we can offer now. Also, you may be aware, before the levo recommendation, we had indicated the use of ethionamide or ethambutol, which some of the studies have used. So the TPT for individuals exposed to drug-resistant strains will have to be tailored based on the drug sensitivity profile of the individual. I hope this answers, although not a clear recommendation as of now. Over.
Okay, thank you, Avinash. Any other questions or comments?
Just to add on what Avina just said, that was, I mean, and it answers the question from a colleague from Nepal as well, because that's why we selected those 12 states that they, I mean, where, testing of index TB patient before choosing the TPT regimen was quite robust. But now it is across the states, and so that's why, I mean, no TPT given to contacts of fluoroquinolone resistance, ARTB, when we have the results. And more evidence, is being looked into if 6-month delaminate is possible. I mean, so that's where we are right now. I mean, we have to decide the TPT based on testing of the industry patient. That is how to take it forward. In states, in provinces, the fluoroquinolone resistance is really problematic. Thank you.
Yeah, thank you, Dr. Nishant. Any other questions or comments? Yeah, please. Yeah, maybe you can use that microphone.
Thank you, Puneet Dewan from the Gates Foundation. I just want to thank the presenters and point out that, especially around screening, there are some areas that are unsolved. For example, what to do with some of the gray zone cases on radiologically difficult, who might be an unconfirmed case, or they might just be old fibrotic TB, who can say? But none of those uncertainties, actually, sometimes we miss the purpose. We see the problem, but we miss the purpose. And the purpose is of the policies that have been discussed is early case finding for the purposes of reduction of disease burden, either those populations or those settings. I think that's very important, that these operational challenges and difficulties shouldn't constrain anyone from pursuing expansion to try and meet the purpose. And I think the examples we heard from the excellent presentation from IT showed that many of those operational challenges are addressable at the implementation level. So I just don't, my point is saying that yes, there are issues that will emerge in implementation and planning, but the underlying purpose behind the policies is sound. And I think the demonstrations have shown that those challenges can be pretty easily overcome. So I don't think we should lose sight of the purpose of the policy when we discuss it. Thank you.
Okay, thank you for your comment. Yeah, please. You may use this microphone. Yeah, yeah.
Okay, thank you. I would like to ask a question about the TPT for contacts who have contacts with the quinolone resistant patients. So yes, so it suggests that we may use PTO and ethambutol, or maybe other drug like Infonix, Delamanid. But any suggestion or prioritization to make the selection of regimen for the contact, for example, like patient who fail from BPAL or BPAL-M, and their contacts should go with PTO or PTO and ethambutol, or for patients who fail from regimen with ethambutol or PTO, like a 9-month regimen should go for the Phoenix approach or something. So we may need a more detailed triage for TPD for contacts of patients with quinolone resistance, or maybe other drug like a linezolid or something. So any suggestion or study about this so far? Thank you.
Thank you. So Avinash, you may answer.
Yeah, I think it's a very pertinent question, and unfortunately, we haven't seen more evidence than what I presented, and also apart from the Phoenix trial, we haven't heard any new data that's emerging anytime soon. So as of now, for this small proportion of individuals, I think one, we'll have to continue with the clinical monitoring, and based on the drug sensitivity profile of the index case, provide whatever option that could be given. But from WHO point of view, we really don't have any specific ranking of regimens or any more recommendation apart from this levofloxacin one that we had recently. Over.
Okay, thank you, Avinash. Dennis, also any additional comments?
And good afternoon, everyone. I'm Dennis Fason. I'm a colleague of Avinash and Cecily. So actually, I wanted to say more or less what Avinash has just said. So it's really very uncertain grounds on what to do in these situations. Probably need a combination of drugs, right? And try to work on drugs that are likely to be still susceptible, or the strain likely to be susceptible to. So the ethionamide, prothionamide is one, cycloserine could be another one. So you're probably in these areas. And we look forward to the results of the Phoenix trial that Avinash has mentioned. And thanks everyone for the efforts, for the initiative. Much impressed. Bye.
Yeah, thank you, Dennis. And then Dr. Nishant, you have raised your hand.
I raised it at the wrong time. Dennis covered what I wanted to say, but I think it will also, every country's drug resistance survey should also guide us in the right direction. Plus, the short answer to patient failing on TPT would be the DST guided treatment, because it has been down into TB. So broken down into TB. So I think DST guided treatment is the for programmatic guidance. I think the countries have to factor in the drug resistance survey data where it points to. I think Vinash and Dennis has covered that already. So I was late in raising my hand. So Thank you.
Okay, thank you, Dr. Nishant. And then maybe we can take a couple of questions or comments more, and then any other comments or questions?
Again, I want to ask, like, when to repeat the TPT? What are the indications for repeating TPT? Whether you suggest for repeat or just a once time? Like if there is again the contact with the another index case, do I have to repeat or not?
Okay, thank you for the question. I think Avinash may answer this.
Yeah, yeah. Another important question. Just to restate what we say in the guidelines, as a policy, we don't recommend systematic repeat of TPT for everyone who had received it before. But we have a couple of exceptions. Uh, uh, as the colleague mentioned, if there is a new exposure which is confirmed, then the provider or the clinician can consider repeat course of TPT. But it will have to be an individual decision. It will have to be made by the clinician at the site, and it's not a systematic, programmatic repetition of the courses. Over.
Thank you, Avinash. Any other additional comments or other questions or comments? Okay, if none, I think we may have lunch time from now on until 2 p.m. So lunch will be served at 18th floor, right? Okay, so let's move to the 18th floor and then take lunch until 2 p.m.
Okay, so yeah, as already Queen said, we'll have lunch on the 18th floor. So, but prior to the restaurant where we're having lunch, so we'll have our team standing outside. So, and please collect the lunch coupon because that's what we need to give to the hotel. So please collect it from them outside. So, and I was told by the team also that if you want, you can leave your bags, laptop here, but make sure you take your wallet out. So, but for your bags and laptops, you can leave it here. Yeah. Okay, see you then after lunch and have a very nice lunch. Thank you very much. Okay, the people online, so we'll be back in an hour. So please, we'll talk to you later. Thank you.
Thank you.
Hello.
Hello, good afternoon, and welcome back. I hope that you have a very nice lunch. Okay, so now you can see that we are a bigger group. So we have the civil society organizations that has joined us now. So, and for the civil society organizations who join us, so in each of the table, so there are at least 2 free spaces. Maybe you can fill yourself and sit on those free spaces. Okay, thank you. So we are going to start, and I'm going to hand over to the chairs, yeah, to take us through on the second part of the day. Thank you.
Thank you. Having a good lunch is a good news and a bad news. Bad news because there may be, the attention may be less than what is expected. So please settle down, and we are about to start. I think the first half has been managed very well. We have kept to the time, and we hope that the same tight schedule can be followed for this session. I hand over the mic to my co-chair to start the session, please.
Yeah, so for this afternoon, we start with the WHO policy update, TB infection testing with TBST and ICRA. So we would like to invite Dr. Pachista have Essen for presentation, please.
Thank you. Thank you to the chairs and to the organizers. It's a pleasure to be with you all today, to see some familiar faces and to meet others that I haven't had the pleasure of meeting yet. I'm representing up here today our diagnostics team at WHO headquarters in the Global Program on Tuberculosis and Lung Disease. But please know that just because I am standing here, this is not by any means only my work this week. You'll see Alexei Korobitsyn's name on the slides. Charlie Nathanson from our team has also contributed greatly to the work that's being presented here. So it's great that we've already started the discussion earlier today in the TB screening session around TB infection testing. What I'd like to do is just provide a little bit of background, again, just to familiarize us at post-lunch with the context for TB infection testing, and then provide you with recent and forthcoming policy updates. So we know that approximately a quarter of the world's population is infected with TB, and that TPT is a critical component to toward ending TB globally. And while this has been touched on, I'd just like to reiterate that our current recommendations do recommend TB infection testing, in part because we don't have the resources, as Cecily mentioned earlier, in order to do mass screenings for everyone in order to benefit them, but also because of the potentially severe adverse reactions that could happen in certain individuals. And so for both the targeting purpose and to make sure that the treatment will benefit individuals, we have specific screening guidelines that recommend the use of these tests, in particular populations that would benefit most from preventive treatment. So our guidelines include a 4-step person-centered process for TB infection testing. And this information has been published in prior operational handbooks from WHO associated with TB infection testing and prevention. But just to quickly say that the first step is to, of course, identify the target population. This is through policy and at the site level as well. The second step is then to do the testing and to review the results, and then to verify those results against the initial clinical evaluation to ensure that TB disease was appropriately excluded and that the patient would benefit without clinical indications for contraindication of TPT use. Then TPT treatment is initiated, and of course, the patient is followed up with TPT through TPT completion in the end. And so, as I mentioned, This table and additional operational considerations for TB preventive treatment have been included in past WHO guidelines. For those that have referenced those guidelines, this was a specific Module 3 book. So this was Module 3 diagnosis, test for TB infection. And that was separate as a resource from our rapid diagnostic tests for TB detection. So there were two separate guidelines here. One of the forthcoming policy, the first that I'll share with you this week, policy changes and structural changes to streamline everything relating to testing into one resource for you as countries, is that we are consolidating these into a Module 3 on diagnosis. And this will include tests for TB infection, for diagnosis, and for drug resistance. So the guidelines will be together, all of the recommendations will be together for these areas, and then also the operational handbook will have considerations for each of those areas of testing, as well as considerations for algorithms for test use. So just to say, I've said the word forthcoming a couple of times. Our 2025 Module 3 consolidated guidelines have not yet been published, but they are undergoing finalization and clearance now for publication in Q2 this year. The latest versions, including some of the information that I will cover today, are available in the 2024 versions on our WHO TB knowledge sharing platform that was mentioned by colleagues earlier. Oh, the slides are not moving. Is there? Okay, great. Wonderful. So for TB infection testing specifically, because we'll talk about the other categories tomorrow during the diagnostics day, WHO recommends 3 classes of diagnostics. So these are groups of diagnostic technologies or products that share similar purpose of use characteristics. We'll go through the class-based descriptions tomorrow for what makes a class. But for today, just to say, these are the 3 categories that you will all recognize at this point, particularly after discussions earlier in the day today. These include the TB skin tests, the interferon gamma release assays, and the Mycobacterium tuberculosis specific antigen-based skin tests, or TBSTs. And so we're going to go through these briefly just to say the recommendations recommend the use of all 3 categories of tests for the detection of TB infection. The products included for TB skin tests include any tuberculin skin test based on PPD. The interferon gamma release assays have previously included the 3 shown in black here on the slide. So that's the QuantiFERON TB Gold Plus, the T-Spot, and the Wantai TB IGRA. And now we have the addition of 2 new tests that I'll discuss today. And the TBSTs include 3, and I'm specifically going to speak about some updates to the PSI-TB assay that was discussed by Dr. Nishant and others earlier. It's important to note that there is no gold standard test still for TB infection, and these tests don't predict progression to TB disease. They remain focused on TB infection. Okay, so I'm going to go through each of the classes relatively quickly, and I'll highlight where there are updates. So for the TB skin test, these of course deliver a standardized PPD cocktail intradermally. These are the traditional tests all of you are familiar with. They do, however, the cocktail of purified protein material does include some antigens that are reactive to non-tuberculous mycobacteria and of course to BCG as well. And so we understand that there can be false positive results in populations that have NTM infection or that have been BCG vaccinated, particularly those that have been vaccinated in the past year. However, testing is considered very safe in this population, and most programs will be familiar with the implementation. Interferon gamma release assays differ slightly, and this is bringing us all up to speed since everyone is not a testing expert. These are blood-based tests. This is where a blood sample is taken by phlebotomy and then taken traditionally to a lab. These tests do require a higher level of infrastructure and trained skilled testers to go through a multi-step testing process in the laboratory in order to get the test result. They are more specific than TB skin tests because they consider very TB specific antigen cocktails, and they have similar specificity to the TBSTs that I'll talk about in a minute. So these are generally the steps of of IGRA testing. You have blood collection followed by stimulation with specific antigens in the lab, and then measurement of your output in order to determine whether the test is positive or negative. Okay, so in 2024, recognizing that the market had expanded quite a bit for interferon gamma release assays, which was very welcome news from our perspective, WHO issued a public call for data and a targeted manufacturer-specific request for data across new interferon gamma release assays. This data was received for 13 new products. That's quite a lot of product and manufacturer interest in the field of TB infection testing, which again, I think is very good news for TB and for TB infection and control. Unfortunately, quite a few of those products did not quite meet the eligibility criteria to then undergo review for assessment. And that criteria was 2 published studies on the performance of the product. And so I'll cover this a little bit later, but that did mean that 6 met the eligibility criteria in order to go through this assessment and review. The data was assessed for sensitivity and specificity with primary analyses looking at published studies, looking at paired specimen data, as well as some secondary analyses that considered unpublished studies. And thirdly, intertest agreement, which was prioritized a little bit lower because there wasn't a shared reference standard. The evidence was put together in a systematic review report and was assessed by our technical advisory group this January as part of the TAG meeting. And so I'd like to share that out of the 6 products assessed, these are the 2 that were found to be comparable with currently recommended WHO IGRAs for the detection of TB infection. So at the top, you have the SD Biosensor Standard E TB Fearon ELISA. This is an ELISA like the others you're familiar with. It's very similar to the QFT Plus for those that have used that test before. The second is the Diasorin and Qiagen Liaison QFT Plus CLIA. So this actually uses the QFT Plus reagents. There's not a new reagent test, but it uses a different detection method with the Liaison analyzer that results in an increase in specificity for this test. So now we have 5 IGRAs that are recommended. Some may remember that the gold in tube and that the gold used to be recommended. These are no longer manufactured by Qiagen. So it's not that their performance has changed, it's that they're simply not available, so they've been removed from the list. So lastly, I'd just like to touch on the TB skin tests. So even though the guidance has been in the latest version, we thought it would be useful to discuss today, particularly given the affordability and cost-saving aspects that many programs are interested in. So these are new skin tests. They use the same antigens as the IGRAs in many cases. They, of course, are still delivered through intradermal injection. And the guideline development group in 2022 determined that their accuracy was similar to that of currently recommended IGRAs. These recommendations are extrapolated for use in persons living with HIV, in children, in adults, adolescents less than and equal to 18 years of age, and for those who have been vaccinated by BCG. It was determined to be cost effective in multiple settings, but there was very limited data on this. So it was based on modeling in several different countries. 2 of those countries were determined to be both cost effective and cost saving. In the United Kingdom, it was found to be 1, maybe not so much the other. It really depends on local costs of what your standard of care is now. Depending on what you're using, but it was found that it would likely be cost effective in most high burden settings. For equity, it was found among those interviewed and among a review of study-based evidence that particularly in settings that are currently using TB skin tests, the equity would likely increase because you're reducing your false positive results and patients value accurate results, of course, as do programs. And then I think there was one more there. Sorry for that. There we go. It's moving forward on its own. Okay, for feasibility, it was determined to be feasible in the settings that were assessed, particularly again in those where TB skin tests are already used, acknowledging that this still requires a 24 to 48 hour of time and a repeat patient visit in order to read the results since it's induration based. Okay. So for regulatory approval and assessments, just as an update, so SCI-TB is the first of these to receive stringent regulatory approval through the EMA. And we have been working with our WHO pre-qualification unit colleagues in order to establish the pre-qualification regulatory approval process for this. The expression of interest has been issued for this product through their medicines listing department and will be moving forward over the coming months. The others will be eligible for pre-qualification as soon as they receive a stringent regulatory approval, since these are considered for in vivo. It is also, as was highlighted by my colleague Avinash earlier, available through the Stop TB Partnership Global Drug Facility at approximately $15 per unit test. And the pre-qualification process for IGRAs, because we know that there are even more that are actually coming to market. We've been contacted by other manufacturers that want to either strengthen their data sets or that have new products that they want assessment. We're hoping to be able to establish that pre-qualification process to move them forward soon. So in conclusion, we have 3 diagnostic classes of tests for TB infection that include several new products and new regulatory approval pathways through WHO in order to test for TB infection and guide TPT for those who would benefit most from it. And we are happy to provide updates over those pre-qualification processes. As the products start going through, there should be a publicly available link online to see where they are in the approval process and those that have been pre-qualified. And again, our guidelines and operational handbook with the consolidation of TB infection and diagnostics testing will be available in Q2. So thank you.
Thank you, Patricia, and thanks for making it crisp and yet comprehensive. Now, we'll defer the questions and answers to after we have this presentation from India, and just like previous sessions, you have the QR codes on your table. So please keep posting your questions if you wish to. Otherwise, you can also ask them live. Now we have presentation from India on TST and IGRA experience. Dr. Nishant Kumar, please.
Am I audible and my slides are visible? Vineet?
Yes, Dr. Nishant.
Is my first slide visible?
Yes, please. Go ahead.
Okay. So thank you, Chair, for giving this opportunity, and thanks to Patricia specifically because she has made my job easier. I just have to now talk about the country's experience, but nevertheless, here are my slides. So under the National Tuberculosis Elimination Program, we have, treat-only policy for, contacts who are less than 5 years and, HIV, PL-HIV, and test and treat for rest of the people older than 5 years old, and household contacts and other risk groups. So this is in term the broad algorithm which we follow in terms of the TB screening, TPT initiation, which includes test and treat policy for household contacts above 5 years, and for other risk groups where PL-HIV and household contacts below 5 years is test and treat policy for TPT. When we talk about other risk groups, so the program has taken a conscious decision on expanding this risk group. Of course, after ruling out TB, these are the risk groups which have been made eligible for receiving the TPT after rolling out the active TB. So Patricia has very beautifully shown the three current options, WHO recommended options, which are there. She also talked in details about the science behind them, but then we have also tried to in terms of the programmatic conditions, TST has been there for quite some time, and it has been there when we say field friendly, because it is there. It is the oldest, but then it has its old issues. And cost of test, if we see, it's as compared to IGRA, definitely low. And if you compare the now SciTB is just, I think, just about $2.5 now. And a TST, I mean, we have BCG available. I mean, the TST and the indigenously developed SciTB is available with the country as an option. And for all three. For the first two, the program budget in their own annual budget, implementation plans, and then as per their experience, their scheme of things, they procure on their own need based. SciTB has been procured centrally and been supplied to the states. Right now, I think two batches are received. And special population for children PLHIV less than 5-year-old, as has been seen, as has been said earlier, they are offered TPT directly without testing. SciTB in India, as I said, this has been validated by ICMR, and now Patricia has said that it has passed the regulatory international regulatory. Slides are not moving. Can you somebody can confirm?
We are projecting from here, so you just let us know when to move.
Okay, right now I am on the TB, the slide which reads SciTB in India. Can I go? Go ahead.
Just give us a second.
It's, I think, fourth or fifth slide.
Yeah, please go ahead. SciTB in India slide.
Yeah, so as I said, this is a point of care skin test, TB specific antigen for Mycobacterium tuberculosis infection detection. It's made in India, has been introduced in September 24. Another TB program, antigen use are the E76 and CFP10. It has advantage of high specificity of 97%. These testing kits are procured centrally, and as I said earlier also that we have procured 5 million tests. It is supplied to the states that procure centrally and is being supplied to the states as an option. For individual in who are more than 18 years of age. So for other we can go to the next slide. How's the about IGRA in India. Again, thanks to Patricia, she has talked about the basic advantages or comparative comparatives of both the three tests. IGRA in India, as she has already responded, it's a blood. I mean, you can take a sample and you don't have to visit twice. One visit is enough. But the problem is the cost. Under the program, these tests again are procured locally at a state level and distributed at the district as per their needs, and they are used for the eligible candidates who are more than 5 years of age. So again, though the cost is a factor, but then this is an option available to the states. Next, we can go to TST in India. So again, as mentioned earlier, that basically this test detects reaction to purified protein derivatives of mycobacterium, is also known as the MON2 test. And this has been the oldest one available under the national programs. Has a limitation of relatively, if you compare low specificity, and again, the implementation in field is you have the patient has to go not patient actually the contact or the eligible person has to go twice. I mean once it is injected and then the intubation is, so that has its own challenges. And these again, as the state or district needs, they use this option as per the local needs there. So the next slide will conclude basically just to give you a sense how it's been, how's the utilization of the three options. So when we see SciTB, it was recently introduced, and the number of, I think we have received 2 tranches, so 39% of that has been consumed. And basically, this is the data, how many IGRA tests done in 2023 and 24 cumulative, and TST used in 23 and 24. So so these are the 3 options, and as per the state's demand and the need be, the states have utilized these options as per their local need. And the last slide, I'll just summarize the program implementation, experiences. So again, when you have 3 options and I would say the nature of technology or nature of science is such that earlier we only had one option, then IGRA came, then tests like SciTB came. So this is how it is evolving, but then it is countries' own needs and cost effectiveness, operational feasibility, implementability, and competency at the field level. So again, you have choices. One has to weigh properly which one to use where and in what quantity. So again, in country like India, it won't be one shoe fit all, but the states are given, SciTB is being procured centrally, and the states have the option, of using the tests available which are there. And of course, the states, as per their needs, budget their requirements, considering the central supply of SciTB. So it's a learning process, and yeah, of course, the basic rule is that we have to rule out active TB before putting them basic and again, as I said earlier in the morning, that first they have to be screened if possible, if the resources are available, with the chest X-ray, and followed by microbiologically confirmation by using the rapid molecular test. And we had some experiences last 100 days. We are getting and analyzing the data, how have we fared in the high burden districts where we carry out this exercise and going out and trying to screen the asymptomatic vulnerable population. So that's this. There are some learnings which we are still evaluating, and of course, recording and reporting of each eligible person about the though we have a module, but the data entry from the field still we are working on to make it much more robust, and training and retraining of staff in the field and ensuring digital entries are recorded. I mean, that's one thing which we are monitoring, and with every review we get feedback from the field as well, and then we review it again and try to sort out and see that we get the accurate data of all the options which we have. And again, it's a learning. Each technology, when it comes, I mean, it just comes with its own pros and cons. So program is very conscious, and with collective wisdom of the expert group, time to time we take a stock of the policies which we have introduced, and then take a decision which is feasible and which is practical and which is cost effective in the long term. So that's our experience of TBSTs and IGRA experience from India so far. Maybe we'll be able to share more regarding the SciTB when we have about a year's implementation experience, and yeah. So this is all from our side. Thank you.
Thank you, Dr. Nishant, for sharing this vast experience. I'm sure you can hear the applause from the audience here. I'm sure there'll also be questions.
The applause goes to TTD team. The applause goes to TTD team. I'm just the one who's presenting. Thank you so much.
Thanks. We started this session 15 minutes late, but beyond that, we are maintaining time. So hopefully the organizers will allow us 15 minutes of question and answer, and I'm sure there could be many of them. So over to the audience in case you would like to ask any of the two presenters any questions. Yes.
Thank you. Thank you, Dr. Nishant. I'm Dr. Naveen from Nepal. I have a questions like SciTB test. As also WHO is recommending SciTB test for TB infections testing. But the temperature control is the main problem. I think 2 to 8 degrees centigrade. You have told that it is procured centrally and distributed to the periphery. But Nepal also has recently procured SciTB test from India. And it is very difficult for us to maintain the temperature in the custom clearance and then sending to the periphery. And even in the periphery, there is no such a refrigerator having 2 to 8 degrees centigrade. So how India is a big country. So how is your experience in transporting this SciTB test from centrally procurement to the peripheral level? And also still we can give it to the age more than 18 years of age. So is there any trial going on for and going to publish soon for the less than 18 years of age or not?
Thank you. Both are very pertinent and very important questions. So I think I mentioned in the slide, but in the interest of time. So yes, temperature. What we are doing is utilizing our immunization programs infrastructure of the cold chain over the long period. We have established the cold chain infrastructure in the country in the immunization program, the UIP, UIP. unified immunization program. So that those facilities are being used for storing in the field. And the second question was, yeah, so the Indian Council of Medical Research has validated it. But the program is taking a internal decision with the expert group of the recommendations, because we always introduce any new policy after due diligence of collective wisdom of clinicians, field staff, and state and district program implementers and the researchers. So it has been it is you will hear it from us soon for the use of people less than 18 years of age. So as we speak today, we are still just firming up on the guidance document and implementing the recommendations of the ICM. Thank you.
Any other questions? Any hands? Anybody online asking question? No.
So by the time the next question comes, just the colleague from Nepal, not only the cold chain, but we have made a lot of SOPs, guidance documents, a lot of trainings has happened, and the vaccine vial monitoring, which was used under the immunization program, is utilized for tracking the temperature for SciTB. Thank you.
Yeah, so my question goes to the WHO colleagues. So because regarding the Mantle test, the TST, so as we mentioned that there are so many false positive, and also the interaction with BCG and also non-tuberculosis mycobacterium. So, and we have already other tests that are demonstrating more specificity. So is there any plans to review the current situation? So with TST, and which one of the tests should we use as a priority for now?
Thanks for the question, Mansa. So at the moment, we do not have plans to re-review TSTs. We recognize that there are advantages and disadvantages between the classes and the types of products. Because TSTs are historically used and very widely used, and because there are settings where BCG vaccination is not as routinely used, where you don't see the impact of the high false positivity rate to the same extent as some settings that have a history of BCG vaccination, we don't anticipate re-reviewing that class now. However, if we get to a point where the market and global use shift and demand shifts, then that could be a possibility in the future. But at the moment, we don't anticipate, say, re-reviewing and issuing a negative recommendation. I think what would be more likely is based on the early experiences that are coming out from Dr. Nishant's leadership, the work with SciTB in India and other settings from the TBSTs, and with the new EGRAs, is that we look forward to hearing and reviewing the literature and learning from you all about the experiences of these different tests in order to be able to update our operational guidance and to better guide countries on how to go about selecting and considering the different pros and cons associated with them.
Any other questions? If there are none from the hall, then let me use this chair's prerogative to ask a question to Dr. Nishant, and maybe then other programs can also join sharing their experience. One of the questions when we go to the countries which is asked is, one important step before testing for infection and administering TPT, and I'm combining both things together, is ruling out active TB. And the programs sometimes are not confident
that they have ruled out, and what we heard in the morning, asymptomatic TB. So there is a gray area there of how you rule out asymptomatic TB before you embark on your journey for TB infection treatment. So what has been your experience, Dr. Nishant, in the field specifically on the confidence in ruling out TB disease and then moving to TB infection testing and treatment?
Thanks, Vineet. I mean, again, it's a very good question, very good question, especially for us because we are going for mass. Going for screening all the possible asymptomatic vulnerables since we have reduced the gap and we have some experience in last 100 days. Yes, not only for program, for individual, it is even more difficult because they have to take the decision there. But the broader guidance, the job of our role is to make the SOPs and make the guidance document as implementable in the field as possible. But you would appreciate that there are situations at individual level where ultimate call is of the clinician or the person doing the who's actually on whose responsibility is to actually document that he or she has ruled out TB. That in that's why I mean it's easier said than done because the medical officer or the field level work the medical officer will definitely may not have any abnormality on the X-ray, may not have those classical symptoms, but again, on individual cases to cases, they may think that it looks TB. So even when TST come, your screening, infection test comes, negative. We try our best. I think the solution would be that what we heard in the morning, those ultra portable handheld devices with CAT, which will give some confidence to the person who's taking that call, and followed by, of course, it looks as a very correct policy that you do the X-ray followed by rapid molecular test. But on ground, these are two different things. I mean, getting the person for X-ray and getting the sample and testing. So yes, these are difficult and difficult to implement, especially in differential geographies like which we have. In smaller geographies, yes, but again, that has that challenge. So, no definite answer of your question, but then I think when we have at least if we when we analyze the data of our experience in last 3 months, we'll be able to tell more, but no definitive answer as such. It's not that easy to actually comment right now. You have put me in spot, but that's why we are here to, we can't have all the answers in one workshop. But this is, I think, this is the purpose of this workshop is to brainstorm and see. But on paper, it looks like really good that you identify your vulnerable population, you screen them all by X-ray, and then followed by molecular test, and you actually rule out TB, and then you put them on TPT. It looks the algorithm looks simple on a paper, but then on field, every frontline worker has and every medical officer will. So I think the solution to that is making as practical SOPs and then keep on reviewing them time to time again. So and specifically, it will be differential as per the burden in different geographies. But yeah, I'll stop there.
Yeah, thank you very much for the answer. And I have one small clarification. This is the on your presentation. You mentioned for the cost of the CI TB test is about $15 per is per dose. Is this is the 15 $15 per test? Is this the? I would like to confirm. Is this correct or not?
You're talking about SciTB?
Yes.
No, it is less than. I mean, it's just about $2.5.
So on the slide, I saw it the $15.
No. We can go back to the slides. No, the SciTB getting is at 250 Indian rupees, which is 200 Indian rupees, which is
Is it the
roughly
15 rupee?
$2.5.
Dr. Wang, this is Zazamunyas. Good afternoon, everyone. I am from GDF, and
Let me comment. Let me comment. I think that was on Patricia's slide, not on my slide.
yes.
For
So
India,
the
it's 2.5.
SEAL TB C is for $15 per pack, but the pack is it can do 10 doses, so that's why it's 1.5 per test.
Okay, it's a 1.5 per test. Yeah. Thank you very much. Yeah. So for the time being, thank you very much, Dr. Niska, for the excellent presentation. So we would like to move to the next section is group work by country group and their partner, including representative CRO for just the country TB response transition plan towards the full update of the latest WHO guidance in screening and prevention. So I would like to invite Dr. Mansa Benga for introduction of the group work.
Okay, thank you very much. And we'll introduce the group work and how we are going to work together on the group work. So, and the main activities of the group work is to make the strategic plan for the introduction of the latest WHO recommendations on TB screening and prevention. So, and for most of the countries that are here, so we already shared the self assessment and planning tool with you so that you can get through it and feel it and come together with it. And we are going to discuss with the planning tool and the informations that you have already filled in the self-assessment and planning tool. So it's not working. Can you go? Okay, so yes, the main aim of the group work is to share the country status on the introduction and implementations of the latest WHO recommendations. So highlights the achievements that the country has already gained. So, and also discuss, the progress that they have, and also the challenges that the country is facing. So using the standards and the benchmarks that are in the self-assessment and planning tool. So, and the main focus area is on the gaps that are affecting the introduction and the implementations. So, and those gaps will be summarized. So, and design an introduction and scale-up plan for it. So, in the tool that we have shared with you, so we already provided the instructions of how to use it. So, and you can see that here we have the standards, so the benchmarks. So, and the idea is that, okay, if all the benchmarks have been met into a standard, so we'll see that the standards will automatically be green. So, which means that we don't need to focus much on the areas that have already been met. So, but now if it is partially met, so it will be yellow. So it means that some of the benchmarks has been met and some has not met. So, and our focus will be on the benchmark that has not been met. So to see what are the challenges that we are facing, what are the difficulties, why those benchmarks has not been met. So, and if none of the benchmark has been met, so it will be red. So, and our main focus will be on the agreed actions. So what are the agreed actions? What are the plans that we can put in place on the challenges that we are facing? So, and design the introduction plan or a scale-up plan, so based on the gaps that we have identified. So, and this is a monitoring tool, so that will also guide us. So on the gaps and the benchmarks, so which needs further discussions and use it for the planning. So, and we have divided the participants, okay, starting with the countries, so that we already shared the tool with them. So, and each of the countries should have this tool by now, so and filled it. So, and the stakeholders also that are here, so each of the stakeholders has been put to a country. So, and for the stakeholders, the idea is that, okay, we'll start with one country, but after 10 minutes, every 10 minutes, so we'll rotate to another country so that we can understand the planning that is going on in also the other countries, and also share our experience also with them. So, and with this, I will list this slide so that you can see it and know to which group you have belonged to. So, and for the civil society organizations, also we have allocated you to each of the groups. So, and you can see that the countries that we have two representatives from the civil society organizations. So we have, for example, like in Nigeria, we have two people. So one will join one country, so and the other will join another country. So, and the same thing also applies to Ukraine. Yeah. So yeah, and for now, maybe I will just call by country name so that we can know where that country is located. So, and from what we see here in the group, so then the one joining that country will move to those country group. So we'll start with Bangladesh. So we are the team. So the team that is joining Bangladesh, so that's the Unit 8 team. So CSO from Nigeria and Stop TB Partnership will join them from there. So Cambodia, so the team that are joining Cambodia, so will be here, so and they should join them. So, and Indonesia, so Indonesia is here. So they are in table 2. Laos, so they are already in here. So which means that already 2 countries are here. So but maybe if you can move to an other table, for example, table 6, there is no one there. So, and you can move from there and other people will join you. So table 6, you can move to table 6. So then all the people join in Laos, so we'll move to table 6. So Mongolia. So Mongolia is on table 7. So, and I know that Mongolia and PNG are on the same table, right? So, and maybe for the team in PNG, maybe if you can move to table 8. So, and all those who's joining PNG will move to table 8. Nepal. So Nepal is here. So, and maybe then we need to find a table where you can just move so that people will join you somewhere in that table. So Thailand is with Indonesia. So, but maybe you can also move somewhere and people will join you. Then maybe if the tables are empty, you will find a table where you can sit with people for discussion. So then Vietnam, we have the Vietnam team in table 5. So, and all those will be joining Vietnam should go to table 5. Okay, so yeah, then we can start moving to each of the groups. So maybe for Nepal, you can go to table 10. Maybe that table will be empty. So, and we'll have 1 hour for the group work. So after the 1 hour, so we will have each of the country for 1 or 2 minutes to share their strategic plan. So where's the team from Nepal? Nepal? Excuse me, where is the team from Nepal? Where are you sitting? Yeah. Oh, yeah. Okay, for Thailand. Okay. Okay, those joining Thailand, so it's on 14. And Vietnam is already on. This is Mongolia, yes. Yeah. Maybe you can join them for now. Yeah. So we find, yeah. You are rotating. Yeah, then you can start with Thailand, so then because you rotate. Okay, I'll rotate. Yeah, 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 yeah. Mhm. So, So, okay, everyone, I've already shared now the tool that we are using, so which is the one for TB screening and prevention. Hello, people online. Uh, hello, online. Hello. For the people online, are you hearing?
Yes, Mansa, yes, we are hearing you.
So, oh, you can hear me.
Yep, yeah, definitely.
Yeah, thank you. So, and I think that we need to work on the group work for now. So, and is the team from Myanmar online?
Yes.
Yeah. So, because you already shared your group work, so the assessment that you have done, the self-country assessment. So, and I think that we can discuss on that self-country assessment.
Yes.
Okay. So, for Myanmar,
I think the program manager from Myanmar is also joined.
yeah. So is it possible you tell me who is the leading the discussions from Myanmar so that we can give that person access to be able to share their screen for the discussion?
Yes, Dr. Tong is, I think, is he online? He is online.
Who?
Dr. Tong.
Dr. Tong.
Yes, I will contact him.
Okay, let me see if I try to give access to Dr. Tong. So then you will be able to carry out the discussion online. So and you can develop what are the strategies that are needed.
Excuse me, Dr. Tong, program manager from Myanmar is trying, and he will lead the discussion on behalf of Myanmar NTP. Yes.
So already joined or not yet?
Yes, already joined. He will, Dr. Tong, his name is.
Tong
Yes,
right?
I'm coming.
Yeah.
Okay.
Yeah. Yeah. Yeah.
Yeah.
He wants to we give access co-host to share the screen. Okay. Yeah.
I will give him permission. Please. Tuno or thầy nano. Tuno.
Yeah.
Tuno or thầy Nam.
So
Hello? Yes.
yeah, Tuno.
Tuno.
Yeah,
Yeah.
yes, I'm Dr. Tung. Yes.
Yeah. Okay, so now we give you access and you can lead the discussions within the team online. So, and maybe you can also report back maybe on the strategies that you have discussed. Yeah, Dr. Tun, do you hear him? Do you hear me?
Okay. Hello, Sir Tong.
Yeah,
Yes.
Yeah, yes. Yeah, I'm joining. Yeah, yes.
Okay, yeah. So then,
It's
yeah,
okay.
you can lead the discussion online. So, and after that, maybe you can discuss about the strategies that you have already put in place for your planning.
Yes, excuse me, who will share the screen?
Dr. Ton, we already give you the access.
Yeah,
Yes.
but please
Maybe
start
you-
us share the
ဒါပေမဲ့အပေးရင်အမကိုစီစီပေးပါလို့နည်းနည်း
Hello.
မှားမှဆိုလို့ကြည့်လို့ရအောင်နော်
Yes.
Hello, Bangna. Could you please share the
Oh.
screen? Because the internet connection is so bad here.
Oh, the internet connection is bad.
Yeah, yes, yes. After earthquake.
Oh, yeah, okay. Yeah.
Yeah. Please share.
Yeah, let me see if I can share my screen. Oh, sorry, I'm coming.
Ya le puseဆရာကျော်လေးအဲ့24နဲ့ပဲအဆင်ပြေမှရှင်တယ်သူပတ်စံတောင်းဒီနေ့ထိန်းနဲ့ကျွန်တော်စတော့ရေးတယ်ရမ်းမြင်24ဆိုတော့24ရက်3လနဲ့ဟုတ်
Hello, Bangna. Is that okay? Or would you provide access to me?
လုပ်လိုက်လေကိုစီအောင်ဟိုတစ်စိတ်တုံးထုတ်လိုက်လေ
We provide access to who?
မတရား
Yeah, you can provide access to me and I will share the screen.
I have access to you, right?
Yeah, yes.
Okay. Yes.
ငါစီကတော့ဖုန်းသက်သေးရဲ့ဗာလဲ
Sorry, can you give access to Hazati? Yeah.
နိုင်ငံလုံးမှာရှိတဲ့ James website ဟိုကပြလာလို့အဲ့လိုပြလိုက်တယ်ဟုတ်
Okay, then. Okay. So okay, then yeah, you have the access. Maybe you can share your screen.
Minutes to go. Hello? 9 minutes to go, is that right?
Yeah.
Gonna make an announcement. Do you want to? Here you go.
Let me finish with these people then after, yeah. So do you have the access now? As I tuned, we already give you access to it. Do you have that access?
Yeah, I already said the well, but
Okay, then.
I'm trying to share the screen.
Okay, then you can share the screen and you can start the discussions with the team. So after that, you can share the feedback when we come back.
See full screen. See. Share screen. Application. Like control. Actually.
Hello, Sia.
Yeah,
we can see your
can
screen.
can you see my screen?
Yes. Yes, we can see, Sia.
Okay. So where we can start. So about the evidence of the political commitment supporting TB screening and prevention for the benchmarks number one, a national strategy plan. So in Myanmar, national strategy for NSP is up to date 2021 to 2025. It also includes the latest racial guidance on TB screen and TBD. So for the benchmarks is METS. Okay. And for the second, high-level political commitment, endorsement, and public pronouncement and commitment to support TB screening implementation of TB nationwide. So it so we also has a high political commitments endorsement. So it's for the description, yes. So for the benchmarks, we write MET. So, for the national strategy, but including TB screening and TBD, initiation for child and adolescent for pregnant women. In the NSP, it include TB screening and TBD for less than for under 5 children is made until 2024. From the 2025 onwards, it will includes about 5. It include adolescent and pregnant men. So for the benchmarks, you write MET. Okay. For the rule, MOH has available for budget to procure 50% of TBD drug, including the RDB contest. So MOH has a budget for TBD, but not to include the RDB content. So For the DRDB, the global fund support for the second line drug, including DVD for DRDB DVD. But now in Myanmar, DRDB DVD is not practicing. It's in Myanmar. So for the benchmarks not met. For the rule, new shorter TBD regimen are recommended, included in national guideline. So it also included in our national guideline. So for the benchmarks it met. For the joint national coordination body exit to support TB screening and implementation TB and scale up, there is no for joint national coordination body for the TB screening and TBD. So, but for this, in this case, this will be discussed in the coming TBDH meeting. So for the benchmark is not met. And for the second heading, there is coordination mechanism on the advocacy and community engagement on TB prevention and screening at national, sub-national level. There is a formal coordination between the NTB civil society on TB and prevention. Yes, TB prevention screening is included in the community-based TB care, which is done by the CSO. So for the benchmark is met. And the second is public awareness campaign. Head talk about the TB prevention and screening is also done by the local VHS as well by the volunteer of the implementing panda CSO. So for the benchmark is met. And civil society group are involved in planning of the TB screening and prevention at national subnational also yes, because it is included in the community-based TB care done by the implementing partner. So for the benchmark is met. For the role, civil society group are involved in the supervision and monitoring of the TB screening and prevention at national and subnational level. Also yes. So for the benchmark is met. And heading number 3, establishment structure that include TB drug on forecasting program and supply and met. Yes, there forecasting mechanism to plan procurement drug for TB. Yeah, TB planning program English forecasting medicine. So the benchmark is met. And number 2, magnesium monitoring country level stock and overstock on TB drug. Also functioning. Also the benchmark is met. Sufficient stock or pediatric formulation for TBD. We'll also have the sufficient stock of the pediatric 6X and 3X formulation. So also maps. And for the next heading, the National Health System has a number of trained staff TB screening and TB initiation and monitoring including DRDB. Yes, the National Health System also had trained staff on TB screen and TBD, but not for the DRDB TBD, because DRDB TB hasn't implemented yet in Myanmar. So DRDB TB will be discussed in the next TB, TWG and TBDS meeting. So for the benchmark is not met. A nationwide training plan on the latest ratio on TB screening and TB initiation and monitoring of the forecast start exit. There is a plan of DOT, contact investigation, TB training at central level, and a cascade training at the state and regional level and township level. So benchmark is met. For the community health worker volunteer treatment support group are trained on TB screening, TB initiation, monitoring, including TBD. In this case, community health worker and volunteer treatment support group are trained on TB screening and TBD, but not for the TBD. So the benchmark is not met. Training on TB monitoring has been conducted for all healthcare workers at secondary and primary level. Yes, the training is done as we have cascade of the training at township level. So the benchmark is met. And the next heading, initial TBD decentralized. Yes, initial TBD decentralized to township level. At this level, added TB is included as before initiation of TB. So the benchmark is met. TB initiated for all content of DRDB, not implemented, yes. So the benchmark is not met. DRDB is included in the national guideline job A SOB healthcare worker train. Is not including yet, so the benchmark is not met. Shorter TB region are available in line with the guideline. Yeah, we currently use 6X and 3XB in Myanmar, so the benchmark is met. Treatment adherence support strategy. For the treatment adherence support strategy, such as accuracy material on TB benefit and initial TB has available. So the benchmark is met and communication civil are involved in delivery TB. Yes, so benchmark is met. Contact investigation, including the RTB, performed for 90% of patient. No, not the 90%. We only do the contact investigation for the intact TB patients, such as battery confirmed TB patient, under 5 childhood TB case, HIV positive TB patient, and DRTB patient. That's not all for all the patients. So for the role contact investigation is not benchmark is not met. And educational material on the prevention for the IEC material, we have another IEC material. So the benchmark is met and TB screening and diagnosis treatments are accessible close to the people home. Here, contact investigation is done as TB for TB contact at home and then refer to the TB center for further process of the diagnosis and treatment. So the benchmark is met. National guideline on TB infection control are in line with the ratio. Yes, so the benchmark is met. A national focus by national copy on TB IBC acid. We already have the RTB DWG member. So the responsibility DRTWG also had the responsibility TB IBC. So the benchmark is met. CSO are involved in TB IBC. Would it come the engagement activity? Yes. So the benchmark is met. Yeah, this is the TB prevention and TB screening session for Myanmar. So. Hello. Hello, can you hear me?
Yes, we can hear you well, yeah, and we can hear the voice from the Hanoi also.
Hello, Mansa. No. Hello.
So ကျွန်တော် laptop က 5% ပဲကျန်တော့တယ် battery ကလေဖြည့်
Yes, yes.
How's yeah? Yes, yeah. Can you join with phones? Yeah.
ဘယ်လို join ကြည့်လို့
Yes, yeah. Thank you. We will let colleague from Hanoi know that your laptop battery is running out, and we'll try to and you are trying to join with phones. Yeah.
No response from their side.
Okay, I will leave the Zoom and I will join again with phone.
Okay,
Yes,
Chair.
yeah, yes.
So the share screen will stop.
Yes,
So
that's
is
no
it
problem. I can
okay.
share, I can share for you, Chair.
Yeah.
Time. So some of you who would like to have tea, coffee, let it be a working tea, coffee break. So you can have it and keep working for another 10 minutes or so. And then we'll reconvene and start the presentations, because then we'll have enough time to give to your hard work of what you are doing or you have done. Okay. How many country groups are ready now? Just raise your hand. 1. Good. 2, 3, 4. So I think you can keep sitting, and maybe we will start. Let me check. Is the Myanmar team online? Can you please speak out? We'll give you the first chance.
Yes, Myanmar is ready.
Okay, colleagues, in case you want to have your tea or coffee, just go out and bring it. We are not going to have a formal break. Maybe we'll request our Myanmar colleagues to start presentation. They have been waiting online. Please go ahead.
So Myanmar you can go ahead.
Yes, please. We can hear you.
Yes, from Myanmar. Good evening, everybody. So I'm Dr. Tung Wu, National Deputy Director for the National Tuberculosis Program, Myanmar. So I would like to present our about the TB prevention and screening. So for the standard column, evidence of political commitment and supporting TB screening and prevention for the Myanmar's National Strategic Plan. We also have in the strategy plan up to date 2021 to 2025 that includes the latest ratio guidance on TB screening and TB. So for the Myanmar's is met. And for the line high-level political commitment, we also have the political commitment on the TB screening and prevention. So Myanmar is met. For the national strategy plan, including TB screening, TBD initiation for children, adolescents, and pregnant women. So until 2024, we also keep TBD for only under 5 children. But from 2025 onward, TBD will be given to the children who are above 5, it including adolescent and pregnant women. So for the Myanmar is met. MOH has available budget to procure 50% TB drug. In this case, MOH has the budget for TBD, but not includes for DRTB contest. So the Myanmar is not met. For the new shorter TBD regimens are recommended and included in national guidelines. So the new shorter TB regimens are also included in the national TB guideline. So the benchmark is met. A joint national coordinating body exists. In this case, we don't have the national joint coordination body. Yes, so we have to plan to develop the joint national coordinating body. And, it will be discussed on the coming TBDH meeting. So the benchmark is not met. For the next heading, coordination mechanism on the advocacy and community engagement on TB. They form a coordination mechanism between the NTB and civil society organization. Yes, TB prevention and TB screening are also included in the community-based TB care, which is done by the CSO. So the benchmark is met. For the public awareness campaign, talk about the TB prevention and screening is done by the local BHS as well as by the volunteer of the implementing partner. So the benchmark is met. Civil society groups are involved in the planning of TB society and prevention at national and sub-national level. Yes, civil society also included in planning of TB society in Myanmar. So the benchmark is met. civil society group are involved in supervision monitoring, so they also involve the supervision monitoring of the TB screening and prevention. That's included in the community-based TB care. So the benchmark is met. For the heading, established structure that include TBD track and focused in the procurement and supply management. Yes, there is a focused team mechanism to plan and procure drug TBD. So the benchmark is MES. Mechanism monitoring of the country level stock and overstock for TB drug. Yes, we also had a plan of the monitoring of the country level stock for TBD drug. So the benchmark is MES. Sufficient stock of pediatrics. So yeah, we have a sufficient stock of the battery, the 6A and 3XP formulation. So the benchmark is also met. For the next heading, training and monitoring plan. The national health system has a number of trained staff. In that case, the national health system has also trained staff on TB screening and TB prevention and monitoring, but we do not have trained staff for the DRDB DBD because DBD for DRDB hasn't implemented yet in Myanmar, so the benchmark is not met. A nationwide training plan on the latest duration guideline for TB screening, TB initiations and monitoring for clinical staff exist. That we have a plan of the TOD conduct investigation and TBD training at central level and a cascade of training at state and regional level and township level. So the benchmark is met. For the community health worker, community health worker, volunteer, and treatment support group are also trained on TB screening and TB initiation and monitoring. So, but not for the DRTB TBD. So the benchmark is not met. Training on TBD monitoring has been conducted for all healthcare worker as a country. Yes, we also have the cascade of training for the local for the community volunteer as the primary level. So the benchmark is also met. For the next heading, initiation to TBD is decentralized. So initiation TBD is decentralized to township level, where the active TB is excluded before giving the TBD initiation. So the benchmark is met. For concerning the TBD initiated for all content of DRDB, DRDB TBD is not implemented yet in Myanmar. So the benchmark is not met. DRDB included a national guideline. Yeah, it is not included yet in Myanmar. So the benchmark is not met. For shorter TBD regimen are available in line with the legal guideline. Yeah, we use the 6, 8, and 3 formulation in Myanmar. So the benchmark is met. Treatment area and support strategy, such as the education material TB based benefit initial TBD are available in Myanmar. So the benchmark is met. Concerning the community-based civil society organization involved in delivery TBD, yes. Scheme 3, the PBN clinics also deliver the TBD. Conduct investing in DRTB performed for 90% of the patient. Now, in Myanmar, conduct investing only done for the intact TB patients, such as pediatric confirmed TB patient, under 5 childhood TB case, HIV positive TB patient, and DRTB patient, but not for all the patients. So 90% is about 50% of the TB patient are done for the conduct investigation. So the benchmark is not met. For the next heading, education and media on TB prevention benefit and TBD and importance, the initial TB in healthy contents are available in Myanmar. So the benchmark is met. For the TB screening, diagnosis, and treatment accessible done to close people home. So contact investigation are done for the TB contact at home and refer the contact to township TB center for the process of the diagnosis and treatment. So the benchmark is met. For the national guideline on the infection prevention and control are in line with the ratio. Yes, we are doing the TB infection prevention and control under the in line with the ratio recommendation. So the benchmark is met. For the national focal point, national community TBC, DRTB DWG has also responsibility of the TB-IBC. So the benchmark is math. CS are involved in the IBC within the community engagement activity. Yes, CS are also involved in the TB-IBC and in the community engagement activities. So the benchmark is math. Yeah, these are my discussion. So for Myanmar. So thank you.
Thank you so much, Dr. Trung. You presented actually the whole tool, which was great, and we could see all what you have done. Thank you so much for your time, and thank you so much for being online. We'll continue with the country presentations, but just to economize on time, we are working on efficiencies in each work that we do every day these days. So from now on, I would suggest that you just highlight 3 to 5 points where you think there is something that needs to be done, and what would be your priority actions for each country based on the tool that you have just filled. So which country is ready to present? Just raise your hand. I think I saw colleagues there on table 8 who had raised their hand first. Table 8. Anyone is ready? Yes, please.
Good afternoon, everyone. I'll be presenting on behalf of our Papua New Guinea team. I'll just present on the ones that is not met and we need improvement. So we have for line 14, public awareness campaigns, NTP-led campaigns. That is not met. So what we are planning to do is to do training. We want to do focus group meetings, workshops. We also want to involve our partner collaboration to achieve those, achieve that benchmark. And then we have another that is under the national treatment guidelines. Line 32, community-based or civil society organizations are involved on the delivery of TPT. That's something that we need to work on. It's not met. So we are planning to deliver, develop the tools and deliver to the treatment supporters. We have treatment supporters in 13 of our province. We have 22 provinces in Papua New Guinea. The other that is in line 33, contact investigation, including DRTB, is performed for 90% of the patients. That's something that we are still working on and we indicated as not met. And our way forward is also for training, focus group meetings, and awareness campaigns. We'll come down to the next indicator, that is the NTP and partners. So for line 35, educational materials, that's something that we did not develop and we are planning and developing. And that's something that we will need financial assistance. And we are working closely with Global Fund is our supporter in that. And we have other partner organizations also in the country that's we are also advocating for that to support us in the educational materials. For line 38, we don't have TB IPC committee, and that's something that we want to work on. After we want to work on that, we have a national guideline on the IPC, but we don't really have something for the TB alone. So that's something that we will work on, and that we said not met. And our last is for the 39. That is a national focal. Oh, that's the one that I'm repeating myself. So that's the something that we will work on to create or come up with a committee, IPC committee for the TB program. Thank you.
Next country, please, Cambodia.
Thank you, Chair, on behalf of Cambodia team, and also from the group member from different partner, some WHO got JATA or IT. So I would summary because we focus on several points around 7 or 6 or 7 points that talking about what we done or update so far. Number one, regarding to the evidence of political commitment supporting TB screening and prevention. This component, let me say, yes, we done for Cambodia and TB. Number two, regarding to the coordination mechanism on advocacy and community engagement on TB prevention and screening at a national and subnational level. Yeah, like we say, done, or we already done and existing. Number three, that regarding to establish the structure that include IPT drug on forecasting, procurement, and supply mechanism management. Yes. And the other point is regarding training and monitoring for plan for healthcare staff on TB screening and prevention. Yes, we already done. And the next one regarding the national treatment guideline, including the latest guideline, include the latest guideline, WHO recommendation on TB screening and prevention, include supportive service. This part we done partially. Some point is still not yet done. Mostly related to the drug-resistant TB. This include the training, screening, and IPT also. Yes, TBT also that we did not did so far. And the next one, NDP partner deploy specific initiative to promote the person and family center approach on the TB screening and prevention. Yes, this point also partially, because regarding training material on TB prevention, benefit of TBT, and the important initial TBT in the health contact. In the healthy contact are available in the community. There is only treatment, only a training manual, but not for TBT, IEC material. Yes. And the next one, the next regarding the care core component of TBT IBT, TB IBT, TBT implemented in the health system and health staff trend. This one we already done. Yeah, that's all from Cambodia side. Thank you.
Yeah, thank you. The representative of Cambodia have presented the Cambodia. The next one, I would like to invite Indonesia, Bangladesh, please.
Good evening, everyone. I present from Group 1, Bangladesh. High-level political endorsement, public pronouncement, and commitment to support TB screening and implementation of TPT nationwide. It is the best benchmark, and our current situation is there is partial political endorsement. Benchmark is not met, and our action plan is NTP is taking initiative for high-level political endorsement, and our time we can achieve it in 2027, our target. Next, benchmark national strategic plan includes TB screening and TPT initiation for children, adolescent, and pregnant women. Current situation, national strategic plan for TPT is already done, but not for screening program. So this benchmark is not met, and we made operational plan for TB screening, and we will develop a strategic plan for TB screening is our agreed actions, and it also 2027. Ministry of Health has available budget to procure 50% of TPT drugs, including drug resistance contact in this benchmark. Our current situation is Ministry of Health is not procuring drug resistance TB drugs, only procuring drug sensitive TB contact. So this is also not made, and our agreed action is we will include TPT for MDR contact in our NSP. Next benchmark I have to mention, TPT is initiated for all contacts of drug resistance TB. It is not met. So our action we will include TPT for MDR contacts in our NSP. And the last benchmark I have to mention, drug resistance TPT is included in national guidelines, job aids, SOPs, and healthcare worker trends. It is also not met, and our action we will include TPT guidelines for MDR contact in our NSP. And our target is also we have to do it in 2027. So thank you all.
Okay, maybe now invite Indonesia to present. You are ready? Need more?
Okay, I will present about the tools from Indonesia. Actually, we already get met for almost all items of this form, but there's only 3 points that are not met. The first one is Ministry of Health has available budget to procure 50% of TPT drugs, including DRTP contacts. Now, the state budget, APBN, and the Global Fund are the primary funding source for the TPT program in Indonesia. However, with then current budget efficiency at the national level, there is concern on drug procurement TPT. A great action is now policy regarding the budget is still currently under discussion at the high level government. The second point is related the coverage of contact investigation. We still not met. Yeah. The coverage of bacteriological contact investigation of bacteriological confirmed about 65%, and contact investigation of clinically diagnosed contacts about 28%. Now NTP is currently developing the new the concept named Desa Siaga, which involve all community for contact investigation and TPT action. The third point related about TB screening, diagnosis, and treatment are accessible close to people homes. Now, not all can access for screening mechanism for all primary healthcare related to the screening using X-ray. Yeah. Because now a portable X-ray still not covered to all region and provincial and district in Indonesia. However, diagnostics and treatment can be accessed at the primary care level. Now, there is a current plan to distribute and placement of portable X-ray at the primary healthcare or puskesmas level. Thank you.
Yeah, thank you, Indonesia. So may I invite next country is Vietnam.
So we would like to mention about 3 benchmarks that we partially met or not met. The first benchmark that the national health system has the number of trained staff on TB screening, TBT initiations and monitoring, including DRTB, TBT. This partially met. The second, that the TBT is initiated for all contact of DRTB. And the third one, that the TBT is included in national guidelines, shop at SOP and healthcare worker trains. And this partially met. And for 3 benchmark met, not met or partially met, we already have the plans for that. So far, the NTP now working with the senior university together to develop the SOP for TBT for the RTB context. And together with that, we prepare to procure, we planning and we do the forecasting to procure the level of fluoxetine for TBT for the RTB contact. And after the SOP available, we will provide the training for staff at all level. In fact, we already provide training for staff nationwide for the STB contact and the other high-risk groups on TPT. But for the RTP, we planning to provide training this year after the SOP available. When we work with the senior university, then the first thing that's after the training done, we will pilot in few district in one province, and after that we gradually extend to the other province in the country. So that's the thing we planning to do with the DRTB TPT. Thank you.
Thank you. And for the next country, may I invite the representative of Laos?
Good afternoon, everybody. Actually, that's all questions. All like everybody knows that for many countries, we based on the WHO recommendation. For Islam context, that of course this I just would like to highlight in terms of that in the benchmarks just here. But of course, this in recent year we try to develop this guidelines, this new guideline. This guidelines is we include TPT, and of course for TPT before many years that we just focus on under 5 years old, and now we would like to expand it for all eligible groups. But why? And it's not starting now because in terms of drug procurement plan is in the pipeline. Maybe coming quarters that we can start for all eligible group. And this is including DRTPT, but of course like DRTB, household contacts that we can trace them with the member of the household, but as you know, that's levofloxacin is in let's say in pipeline also. Maybe Q3 of the year we can start TPT for DR household contacts. In terms of community engagement and empowerment, this is in the country. Laos is we have only 2 CSO who's working for TB program, and the numbers of side project, the province or districts is really limited. Means CSO just support 1 or 2 provinces. That's compared to other country like Cambodia or Indonesia is big support from community is different. But anyway, we try to convene to Moha, is the Ministry of taking care about that CSO, to be part of TB support in the community. We try to launch with the malaria program. We have good implementation in terms of community engagement, because they have like a health volunteer at the village level, at community level. But for TB and HIV, we just starting how to integrate that's TB and HIV and malaria program together. And again, in terms of education material and patient care center, now we have policy from MOH to is centralized, of course, but this centralization is now limited. Why? Because the funding like publishing or producing of material is the funding gap is limited. So maybe, of course, that we need full support. For public awareness and campaign, that's we have just conduct like many countries, let's like a World TB Day. That's where leaders of MOH and WHO and development partners and with all the line ministry and society to involve to celebrate for TB Day. And we have like a signboard and cross the road and some events. This is some kind of example. Thank you.
Thank you, Lo. Can we now invite our colleagues from Mongolia
if they're ready.
Good afternoon. Currently we have very few issues. First benchmark is a joint national coordinating body exists to support TB screening, implementation of TPT and SCADA. Not met. Our current situation is NTP provides overall coordination, but no specific joint coordination body between TB screening and TPT implementation. The NTP will consider the approach for improving coordination to support TB screening and TB implementation. It will be end of this year. Next benchmark, TPT is initiated for all contacts of DRTB. In Mongolian situation, coverage is very low currently. We planned routine trainings for TB doctors. Next benchmark, contact investigation, including DRTB's performance for more than 90% of the patients. Our current situation, approximately 60 to 70% of contact tracing. We also planned TB patients and their close contacts. We also planned advocacy activities for DRTB patients and their close contacts, and also we established psychological counseling team in the NTP, supported by Global Fund project. And finally, CSO are involved in TB IPC within community engagement activities. Current Mongolian situation, IPC not specifically included. We included our new NSP this point. Thank you.
Thank you, Mongolia. Can we request Nepal, Dr. Naveen? Yeah, so you can pass on the mic there.
Okay, so I'm not from Nepal, but I've been volunteered to present on behalf of both Nepal and actually Thailand. We're going to do both together because we did it together as a small group. I'm Mike Frick from Treatment Action Group, for those who don't know me. I want to start by talking about areas where the two countries really excel and stand out. It was very impressive that in both Nepal and in Thailand, the governments are using almost entirely domestic resources for TPT procurement, including in Thailand, they had some grant support for rifapentine, but starting this year and next, rifapentine will be used on domestic procurement, and Nepal is doing direct tender with manufacturers in India. And Nepal has even procured the pediatric dispersible rifapentine formulation for kids, which was very impressive. And both countries have very up-to-date guidelines that recommend shorter TPT regimens, although when it comes to DRTB contacts, we'll talk about that. Some areas that were partially met or not met included involvement of community and civil society. They're included in things like technical working groups. Nepal does have local level TB-free Nepal chapters and a chapter of TB people, but CSOs are not so involved in monitoring TB screening and TPT programming. And in Thailand, the role of CSOs is more limited to working with migrant populations and sort of specific populations rather than kind of full integration into TB screening and prevention programs. When it comes to DRTB, we had more to discuss. Nepal, as I understand it, has sort of made a decision not to move forward at this time with the 6-month levofloxacin regimen based on kind of high rates of quinolone resistance in their country. And so they're really waiting for research on alternative regimens for contacts of DRTB